أنا أحس can the other co-host please just make your mic mute for some time. Only Hamad will put it on, and the guest of honor, Dr. Mariam, and myself only. Thank you. Okay. Yeah.
So we'll start now.
Yes.
Good evening, everyone. Assalamu alaikum wa rahmatullahi wa barakatuh. This is Hamad Subhi. I will be the host of this webinar. On behalf of the organizing committee today event, it is my great pleasure to welcome you all to this live webinar. Rehabilitation services against COVID-19 pandemic, international perspective, which is organized by Department of Medical Rehabilitation Services at Ministry of Health in collaboration with the Smart Cities Platform and Oman Physical Therapy Association. We are very grateful to have you all here today, despite the challenges imposed by this pandemic. Before we start the program, I would like to welcome our event guest of honor, Dr. Mariam Al-Waili, Director of the Department of Supportive Services at Directorate General Specialized Medical Care at Ministry of Health, for start our opening remarks of this event. It was said there are certain life lessons that we can only learn in the struggles. So, welcome Dr. Mariam Al-Waili. The mic is yours.
مريم.
افتح الفيديو.
فاتح شغال بعيد.
وين الصوت؟
ما لازم تشوفه شغال.
Yeah. Good evening. Can you hear me?
Yeah, this is clear.
Yeah, can you hear me?
Yes, قاعد clear.
Good evening. The Directorate General of Specialized Medical Care, Ministry of Health, Oman, welcomes you all to this scientific webinar titled Rehabilitation versus COVID-19 Pandemic. I'd like to welcome our distinguished speakers from WHO and abroad, and also I'd like to welcome all our in-house speakers. On the 30th of January this year, the WHO declared a state of emergency to combat the spread and impact of COVID-19, a disease caused by the novel virus SARS-CoV-2. As all of you know, the pandemic has placed the healthcare system under great pressure all over the world, and we are no exception. It has affected the delivery of regular healthcare services in our countries and has put great pressure on healthcare providers and their families, which has affected drastically our healthcare plans and strategies. Just like all disciplines, the rehabilitation specialties have been impacted by this pandemic as some services become suspended, delayed, and suffered from shortage of human resources. During these illnesses, patients may develop a myriad of acute medical problems, and their treatment requires invasive procedures, all of which can cause mid and long-term consequences requiring rehabilitation. This has led to an increased interest in the role of rehabilitation services in the patient's recovery plan. This interest is further fueled by how the consequences of quarantine, social isolation, movement restriction, and healthcare system are disrupting the routine rehabilitation of patients with disabilities and chronic diseases. Thus, it is ever more important to communicate the currently available evidence to reduce any resulting clinical uncertainty. The Ministry of Health in Oman considers human resource development a priority for achieving the healthcare outcome and implementing the training integration in various scientific and practical fields. Within the framework of healthcare system, rehabilitation specialties are playing a crucial role in fighting the COVID-19 pandemic, working with their colleagues in other healthcare disciplines as one team during these uncertain times. Indeed, it is my pleasure to see you all gathering here today in line with the Oman Vision 2040 in healthcare system, in which one of the objectives is technology-driven medical system and services and high-quality preventive and clinical healthcare across all levels, standing on the challenges that health systems are facing in different countries and suggesting solutions to overcome these challenges. The Directorate General of Specialized Medical Care at Ministry of Health, Oman, gives special interest in the developing and qualifying health competencies in order to achieve the highest level of healthcare equality. We thank you all for your participation, and we hope that you benefit from the scientific event. Thank you.
Thank you, Dr. Mariam. And now, please allow me to present Ms. Samia Raisi, Head of Medical Rehabilitation Department at the Directorate General of Specialized Medical Care at Ministry of Health.
Thank you, Hamad. Bismillah ar-Rahman ar-Rahim. Dear guest of honor, my fellow colleagues, and honorable speakers, and dear students. The COVID-19 pandemic has brought unexpected challenges to the world. After the outbreak of COVID-19, the countries have adopted different approaches to contain the virus according to the local context. They have effectively curbed further a widespread infection and taken measures to ensure safe and smart return to daily life. Knowledge sharing on the approaches and measures in dealing with COVID-19 pandemic among the countries and stakeholders is critical for their effective response and swift recovery from the crisis. This webinar is organized by Medical Rehabilitation Services, Ministry of Health in collaboration with the Smart Cities and Oman Physical Therapy Association. It aims to provide a unique opportunity to get first-hand accounts from international and national experiences on their COVID-19 responses and discuss their views on key challenges and forward-looking strategies. As we have seen, the pandemic has extremely reflected on the social life of healthcare workers and their families. On this aspect, we are aiming today to explore the psychological impact of COVID-19 pandemic on healthcare workers and service users. The rehabilitation services are provided with specific techniques which require a direct contact with the service users, which put us under great pressure on how we safely deliver the service, paying in mind all precautionary measures. I hope that today we can discuss the strategies that ensure the continuation of the service at times of crisis and approach the technology to achieve the desired outcomes. Likewise, the future recommendation will be highlighted in order to avoid impacts of such similar circumstances. I'm really pleased to see this large number of attendees from different health specialties in different sectors in the Sultanate and globe, which indicates that we all are here together to build healthier, safer, fairer world we all want to see. Thank you once again.
Thank you, Ms. Samia. Dear participants, the wonderful thing about this webinar is the international perspective our members bring to these discussions. We are very glad we found a selection of speakers prepared to share their experiences and the use of the technology toward the development of the rehabilitation services. The speakers in the webinar are uniquely placed to explore and share their international experiences, trends, and current practice to the audience. We will be learning strategies to overcome the existing challenges in rehabilitation fields. The webinar is divided in 2 seasons. Season 1 is going to cover the several experiences from the different countries along with the experiences of the Ministry of Health within the contents of rehabilitation. Season 2 will be demonstrate the solutions and strategies which are made to face the challenges of the COVID-19 pandemic. That is why we call the season is Battle Strategies. Before we start the first season of our event, I would like to cover a few housekeeping points. Today's webinar is being recorded. We will be able to share a link with you after the event is complete. We welcome you to revisit the content yourself to share it with the colleagues. Please be aware that you are set all muted. We invite you to, your comments and questions. Please look at the chat box on the right side of your screen. If you think of a question for the speakers at any point, just type it and will be either posed to our speakers' time and hold it for the discussion portion at the end of the season. Kindly note that the evaluation form will be sent to all the attendants through their emails, and e-certificates will be provided to the event's participant who will attend the full season. So please stay till the end of the event. E-certificate will be sent to all the attendance participants after filling the evaluation, which will be sent later. I sincerely hope you will enjoy this webinar and have a productive day. Thank you for participation. At this stage, I would like to introduce Mr. Mohammed Ashmeli, who is going to lead season 1. Mohammed Ashmeli is, second please. Yes, Mohammed Ashmeli is a physiotherapist who graduated from Sultanate of Oman. He's working at Sultan Qaboos University Hospital. He's more experienced with pediatric cases. Please, Mohammed, this floor is yours.
شكرا حماد. السلام عليكم ورحمة الله وبركاته. Welcome you again in this visual meeting, and we are all lucky to see you with us, and it's a good opportunity to meet during this pandemic and during this time. And as you all know, this pandemic actually affecting worldwide, and we have so many experience regarding this issue. And also we are happy to have experience from our country, Sultanate of Oman, and we have another experience from international, from other countries, to share with us this pandemic issues. At the beginning, we'll start with Dr. Lamia Mahmoud. She is from Public Health Specialist in WHO, with Dr. Hala Sakr, also Regional Advisor from WHO. They are going to speak about rehabilitation consideration in the context of COVID-19, WHO perspective. So I leave the floor for them. Doctors, welcome with us.
Assalamu alaikum wa rahmatullah. Good afternoon, everyone. I bring you warm greetings from WHO at all levels of the organization. Dr. Hala is sharing our slides. And the 2 presentations that WHO is delivering at the outset of session 1 are complementary to each other. So WHO, in view of its technical mandate, of course, has been working at all levels of the organization to develop the guidelines and resources that would help its member states to manage rehabilitation in view of the COVID context, as well as in non-COVID patients. And of course, also WHO, very relevant to its mandate, is the issue of generating evidence. It has been working along those lines to ensure that member states are able to develop short-term and long-term strategies to manage this. And also WHO is providing technical assistance to countries. So as I mentioned, the two presentations are complementary. And in this first presentation, Dr. Hala and I will be talking about rehabilitation as an essential service. It is, of course, necessary, a necessary service for many people so that they remain healthy and they remain as independent as possible and are able to take part in education and economic activities. In this way, they would be able to lead fulfilling and meaningful lives. And of course, the need for rehabilitation services is very much driven by the current burden of disease. It's driven by the increasing burden of NCDs, by the injuries, disabilities that we're seeing. In addition, the aging population around us and the disasters and emergencies that are happening across the globe, but more so in our region, in the Eastern Mediterranean region. All these factors are increasing the need for rehabilitation services. However, we do note that even prior to COVID, there was some shortage in all parts of the world. There was a substantial unmet need for rehabilitation services that was not being met or provided, in addition to the limited capacity to provide rehabilitation that we were seeing worldwide. However, universal health coverage and its definition and the way it is framed does include rehabilitation as an essential service. And also it's an integral part of the continuum of care. And the way we frame universal health coverage is that such that all people will have access to health services that they need when and where they need it without any undue financial hardship. And the term universal health coverage includes the full scope of health services that range from health promotion to treatment to rehabilitation and even including palliative care. So the way we look at it, there are two perspectives that need to be addressed. We need to look at, as I mentioned earlier, rehabilitation for COVID-19 patients. And this component will be dealt with in the next presentation by Wouter from WHO headquarters. And we also have rehabilitation for non-COVID-19 patients, which is being dealt with through this presentation. So we do recognize that rehabilitation needs will continue and of course even will increase in view of the COVID-19 pandemic. We have seen that with the pandemic, with the consequences of patients contracting COVID-19, they'll also need some rehabilitation services. And of course, also those who previously needed COVID rehabilitation services, even without COVID, will need the service. And the lack of access to rehabilitation can have many serious consequences. At the individual level, it compromises the health outcomes for these patients. For the health system, it also creates an extra burden. It will extend the inpatient stays that these patients will require. It will also result in preventable hospital admissions that would have not been necessary had these patients received rehabilitation services early on. And it's important to recognize that rehabilitation services do not come at the end of the illness. They could be needed along the way as the patient is receiving their treatment. I'll now hand over to Dr. Hala to continue with this presentation.
Thank you so much, Dr. Lamia, and thank you everybody for giving us the opportunity to present on behalf of WHO country office and regional office and headquarters. So as Dr. Lamia mentioned, rehabilitation is seen by WHO as part of the essential health services. These services were impacted by the COVID-19 pandemic. And in this regard, WHO, to address this and in response, WHO provided and published guidance on rehabilitation considerations during the COVID-19 pandemic. And this is the guiding document so far for us in terms of rehab for non-COVID patients. So at the regional level, in order to be able to have a better picture of what happened in terms of disruption of rehabilitation services, the findings of a global survey on non-communicable disease-related services during COVID, an analysis was done of the regional findings. And it was found that rehabilitation services for non-communicable diseases were disrupted partially in 26% of countries, so almost quarter of the countries, and a little bit over a quarter of the countries, and were completely disrupted in a little over 1/5 of our countries. So this is what was reported by the participating countries. Now, this disruption was due to different reasons. On the supply side, this was due to the diversion in part. I mean, these were what countries thought and what we thought. The disruption of services and its unavailability due to different reasons, including, for example, closure of different services and different service delivery points, especially at the beginning of the pandemic. The other issue was the workforce, the lack of the required workforce to deliver the services, because this workforce was at many times shifted to the COVID-19 management for the cases. The other issue was the insufficient supplies of personal protective equipment, or the lack of the required supplies in some cases. So these are examples of reasons for disruption that were reported by countries on the supply side. On the demand side for the patients were simply at many times afraid to go to the hospitals or to seek care because they did not want to get infected, and they thought that this might increase their risk of getting infected. Or there was this perception that they thought that the lockdown that was imposed as a measure to address the pandemic could hinder their access to the services. Or, for example, the financial hardships that many people were exposed to or suffered as a result of the pandemic, which hindered their seeking the required services that they needed. So these are examples of some of the reasons that were provided during the survey by the respondents from different countries on the reasons for disruption. Another activity that we took at the regional level, but I mean, it is yet to be published, is a rapid assessment of disability inclusive COVID-19 health response. And one of the questions was whether the essential health service continuity plans in countries included rehabilitation and assistive technology services. Among the 17 countries that participated in this rapid assessment, 10 countries reported that indeed rehab and AT were part of their essential health service continuity plans, while 6 reported that they were not, and 1 country only said that they did not have such a continuity plan in the first place. However, although these 10 countries reported that rehab and AT assistive technology were part of the essential health service continuity plan, we did not know how this played down out on the ground, how it was implemented, at what level of the health system these services were delivered, and did they really reach the people in need, and the extent to which this happened. And of course, this entails a more in-depth assessment that could probably, we hope that we can have an opportunity to do this after the pandemic resides, inshallah. So in our endeavor to ensure the continuity of these services, essential health services, the rehabilitation in particular, we need to realize that there are priority patient groups for whom this is essential. It is crucial to continue providing rehabilitation services for patients with new acute injuries, such as burns, such as amputations, such as spinal cord injuries. These patients may develop serious preventable complications if the rehabilitation services that they need are not provided. Patients recovering from surgery, patients with conditions who are at risk of suboptimal recovery, such as those recovering from stroke, myocardial infarction, or for that matter, perinatal complications, patients requiring longer-term regular rehabilitation. They may experience issues related to their functioning, or they can develop complications if the services are disrupted. Patients who are not able to be discharged to a setting that is safe, or they cannot return back to their settings because of long distances from the services that are likely to preclude them from future access. So these groups of patients need to be taken into account based, of course, on the resources and the mechanisms and the context in the different countries. As we endeavor to ensure the continuity of rehabilitation services to these priority patient groups, there are a number of factors that we hope would guide the decisions, the decision-making level for the service delivery, the delivery of rehabilitation services. One issue is the context of the pandemic itself, the extent of spread, the impact of lockdowns, and the guidelines that are in place, so of course, especially the national and the local guidelines. The risks that are associated with the reduction or the complete cessation of the services for the different patient groups. We said that there were priority patient groups and there were risks that were linked to the disruption of services for these patients. The other factor that we need to look at and take into account is the feasibility and appropriateness of resorting to alternative modes of service delivery, such as telehealth. And I could see that there is a presentation that is dedicated to this issue, the type of rehabilitation, telecommunication, the infrastructure for this, and the economic costs. And of course, we're talking about a pandemic. We are working with a pandemic with high risk of infection for the patient or for the healthcare providers. And so access to the personal protective equipment and the robustness of the infection prevention and control measures is instrumental and is key in different contexts, let alone the capacity of rehabilitation workforce to retask and the ability to do some task shifting and make use of some of the related health professionals or professions that could help in improving or increasing the health workforce for rehabilitation, such as community-based health workers, such as the community health workers themselves generally, not only the CPR workers, such as the different health professionals that are not specialized in rehabilitation, if they are available, if they are there, because we know that, as I said at the beginning, that most of the health workforce were diverted or shifted to address the pandemic, especially at its beginning. So what are the potential actions to take in this regard? How do we think we can do it? Involving rehabilitation workforce in the discussion, and for that matter, service users as well, in developing the decisions around service provision and how best to do it from the community level up to the very specialized tertiary level. This is important to understand the needs, to understand the different modalities, and they can have very innovative and ideas that are simpler or less complex than we think. Of course, it is important to have, as appropriate, the more sophisticated solutions, but then there are solutions that can be done that are feasible and appropriate to the different levels of the health system. It is important to prioritize services and patients, as we said, based on risk, based on need, while considering the alternative methods of service delivery, wherever it is safe and effective. Access to PPE, personal protective equipment, is, as I said, crucial. And where face-to-face rehabilitation, it is important to repurpose the non-COVID rehab workforce towards the alternative modes of delivery. Telehealth, advice lines, developing self-management plans and home programs, the ability to provide some basic rehabilitation services, such as at the community level or the primary healthcare level. I mean, there are different issues. And I think that one of the good things about the pandemic is that it sort of pushed us all to try and be as innovative as possible. And then I come to our very last slide. Which are the key messages? The key messages in the rehabilitation considerations for COVID were for both non-COVID patients and COVID patients. But here we will focus on the key messages for the non-COVID patients, and I will leave the COVID patients to Wouter. So for governments, with the adjustment to delivery and rehabilitation, rehabilitation services can continue. It is important to include rehab in the COVID-19 health planning and make necessary adjustment to health financing. It is important to increase the capacity of rehabilitation workforce. It is important to support ongoing access to rehab through maintaining select or priority services, expanding the delivery of telehealth and in-home services for non-COVID-19 patients. As I said, this is related. These are examples of the key messages from the rehab considerations document, focusing on non-COVID rehab services. And we leave the COVID aspect, the COVID-related rehabilitation to Wouter. For service providers, we will never cease to underline the importance of infection prevention and control measures on access to PPE. We will never cease to repeat and repeat and repeat. These are essential for continuation of rehabilitation services and to protect both patients and service providers from getting infected. Service providers should undertake different actions if rehabilitation is reduced. Some of these actions include the prioritization of patients for ongoing care, providing early supported, and this is very important, discharge, and developing systematic follow-up mechanisms, and perhaps having some home-based programs or for them to, or self-management programs for them to be able to cope with their needs during the pandemic. Also, the modifications in service delivery is required for infection control, and we said, including changes to team structures, roles, and means of communication. So basically, it is important to try and do our best to maintain the essential rehabilitation services as part of our endeavor to ensure the continuity of all essential rehabilitation services as part of universal health coverage for all those who need it during the pandemic. These services are of utmost importance and are a life-saving line for patients who need them to continue being healthy, independent, so that they do not develop any unneeded complications that could have been prevented, and be able to continue their life in a meaningful way. Thank you so much.
Thank you, Dr. Lamia and Dr. Hala. Now we are going to the second topic. It's going to be about rehabilitation as a part of clinical management of COVID-19 patients. Dr. Wouter, he is WHO consultant in rehabilitation program. He is going to talk about this issue. So welcome, Dr. Wouter.
Good evening, everybody. Thank you, dear chair, and all participants for having me. My talk today will be about the hands-on rehabilitation clinical management for COVID-19 patients. So I will discuss rehabilitation needs And then we will tackle interventions, different interventions that are possible to provide by rehabilitation professionals in COVID-19 patients. Let's first look at the rehabilitation needs. And as you see in this table, you see the different disease severity types of COVID-19 presented according to the WHO classification system and their clinical management. At the outset of the pandemic, we were anticipating rehabilitation needs based on the evidence of the general critical care population and their management at ICU, as many of them might develop the post-intensive care syndrome with physical, mental, and cognitive impairment types, as well as dysphagia post-intubation and sometimes a tracheotomy. But then when the pandemic continued, there was an emerging evidence on persistent symptoms in COVID-19 patients that was unrelated or was in all disease severity types presented. And the prevalence of these persistent symptoms seems to increase with the disease severity type. And it is a cluster of symptoms that is dominated by fatigue and breathlessness. But there's also other symptoms like anxiety and depression, what we call a brain fog with difficulties with memory and concentration and problem solving. There might be a persistent pain or even dysphagia. So for now, we know, and these are data from high-income countries, that 50% of all hospitalized patients will present with fatigue at 2 months follow-up. Next to this post-intensive care syndrome and persistent symptoms in the COVID-19 population, we also have complications that have been reported through case reports, and there are many. And as you can see, they are covering many clinical domains. And these complications might result from a thrombotic event, such as a ischemic stroke or an ischemic heart disease, or they might result from direct neuroinvasion with meningitis or encephalitis, or they might result from an immune-mediated reaction resulting in a Guillain-Barré syndrome. Many of these complications are amenable for rehabilitation, and these are other COVID-19 clients developing extra needs for rehabilitation. So in general, we have 3 clinical types of rehabilitation needs. We have the COVID-19 patients whose acute illness required intensive care and who are susceptible of developing the post-intensive care syndrome. We have the COVID-19 patients who have serious complications, as just addressed. And then we have the COVID-19 patients with a persistent, non-specific clinical picture dominated by fatigue and breathlessness. So what are the objectives of rehabilitation in the different phases of illness? Because rehabilitation professionals will play a role in these different phases of illness. And in the acute phase, which is the clinical phase with respiratory failure, and the focus will be on survival, rehabilitation professionals will be involved in optimizing oxygenation, manage secretions, and prevent complications. In the sub-acute phase of illness, which is the convalescence phase with activated immune response, there will be still respiratory failure, but there will be consequences of inactivity and immobility, and some complications might have occurred. And rehabilitation professionals here will need to identify and manage impairments for potential affected clinical domains, prevent complications, and facilitate onward referral. And then in the chronic phase, rehab professionals will be dealing with potential sequelae in order to optimize functioning and minimize the impact of the impairments on the independence and the quality of life of the COVID-19 patients. So currently, WHO is developing guidance on the rehabilitation clinical management for COVID-19, and it will have some recommendations. So I'm happy to share with you some of the recommendations. It says that in hospitalized patients during the acute phase of illness, rehabilitation professionals may provide interventions that relieve respiratory distress, prevent complications, and support communication. So what could these interventions be in the acute phase of illness? First, there's the early mobilization, which is re-engaging in physical activity and may start as early as in the ICU setting, guided by the level of sedation of the patient. And this is indicated for all patients that have a severe risk of functional limitations resulting from frailty or ICU-acquired weakness. Rehabilitation professionals will also be involved in optimizing oxygenation, and this can be done via active cycle of breathing techniques like deep breathing techniques and positioning techniques like in verticalizing the patient, which facilitates thoracic expansion and improves ventilation to the lower lung areas. Sometimes airway clearance or secretion management might be needed, but this is only indicated for COVID-19 patients developing an exudative consolidation or mucus hypersecretion, or in patients with coexisting respiratory or neuromuscular comorbidities who have already difficulties with hypersecretion and ineffective cough. So these techniques will include positioning with gravity-assisted drainage, again, the active cycle of breathing techniques with huffing, with a patient having a forced expiration with open mouth, positive expiratory pressure therapy, and assisted or stimulated cough maneuvers. But then we need to take into consideration some findings that are crucial when dealing with respiratory physiotherapy, because many interventions combining cough for airway clearance are potentially aerosol generating procedures. And the therapist should weigh the risk versus the benefit and consult with a medic. And whenever this intervention is considered essential, it is recommended to provide these interventions in a negative pressure room, if available, if not in a well-ventilated isolation room. In any case, airborne PPE precautions should be used, and single patient use disposable options are recommended, such as the use of a PEP device. Always monitor oxygen saturation levels closely, because in the early phase of mobilization and positioning, a desaturation may occur. And in that case, you might want to increase supplemental oxygen therapy or even pause and stop rehabilitation activities. Whenever you're confronted with a severe shortness of breath that is not relieved by positioning or breathing techniques, you should seek for further medical investigation. Rehab professionals will also be involved in the education for breathlessness, which is crucial, and patients will be advised to stay calm by using positions or breathing techniques that help to manage their breathlessness. And as you can see in the figures, there's a few positions like high side lying or forward lean sitting on a table or without a table that help to control breathing. Or you might introduce some breathing techniques such as the pursed lip breathing. So the patient will be inhaling through the nose and then exhaling through the mouth with pursed lips. Or you might want to introduce the square box breathing, which is using a count of 4 for every step of the breathing cycle. Always educate about activity resumption and fatigue. And this is crucial in COVID-19 recovery. Patients should resume everyday activities at an appropriate pace that is safe and manageable for energy levels, and never push for post-exertional fatigue. During the inpatient period, the activity level should remain low, and even after that, it will continue with a low to moderate level of activity for 6 to 8 weeks beyond discharge. If confronted with dysphagia, and you know that some ICU survivors that have been intubated might suffer from dysphagia and will have an increased risk of aspiration pneumonia. So whenever you have a client that is coughing or choking when eating or speaking with a weak, wet voice, be alarmed and assess with fluid trials on dysphagia. And then you will use compensatory techniques such as changes to food and drink consistencies, and you will advise on safe swallowing body postures. And then you might want to refer to the speech and language therapist if available for restorative exercises for swallowing. So what happens at the end of the inpatient stay? Prior to hospital discharge, rehabilitation professionals should screen COVID-19 patients for rehabilitation needs in order to facilitate their onward referral. And then the rehab professional would assess oxygen requirements at rest and during exertion, because many patients may have ongoing oxygen needs in their recovery phase, and oxygen desaturation might happen even with moderate activity levels, which is unrelated to the saturation level at rest or the degree of dyspnea. And then, of course, you will look and check whether your patient needs an assistive product such as a mobility aid. And then based on the continued rehabilitation needs, you would refer your client to the home setting or outpatient rehabilitation service or even inpatient rehabilitation services, of course, all depending on factors that you consider and that are available in your country, as just discussed in the previous presentation. When in the subacute and chronic phase, patients that have been discharged from the hospital or patients who have been managed at home and still experience persistent symptoms or limitations in functioning, make sure to screen for physical, cognitive, and mental impairments and manage accordingly. So if limitations remain for longer than 6 to 8 weeks from onset of illness, you might want to refer for further assessment and rehabilitation. And then your rehabilitation interventions will be based on symptoms. And as I have explained earlier, these persistent symptoms often are a cluster of different symptom types, but are dominated by fatigue and breathlessness. And then typically pulmonary rehabilitation programs will be prescribed, which commonly take between 6 to 12 weeks, consist of aerobic exercises, and are based on the desired percentage of your optimal oxygen uptake. But then again, in COVID-19, we need to be cautious because often it is not well tolerated and people have a variety of oxygen needs and breathlessness on exertion. And there's even a risk of physical deterioration when sticking to these gradual increasing training programs or high intensity training. So the recommendation for graded exercise might not apply for the COVID-19 population. So pulmonary rehabilitation programs should be patient-tailored for the COVID-19 population with a flexibility to adapt for gas exchange abnormalities and always be using a baseline oxygen need at rest and during effort, and always be supervised. And monitor your program with clinical signs for desaturation and a breathlessness scale. So one of these breathlessness scale is the Borg scale. The Borg scale is a scale that is used to monitor exercise intensity. And in the subacute phase or in the initial 6 weeks after discharge, we are recommending to keep your shortness of breath below a level of 4 on 10. So the patient would not exceed the level of shortness of breath, that exceeds the moderate level. Also, for people with persistent fatigue on exertion and breathlessness, educate, because many of them will need to modify their behavior, to adjust expectations, and to respect rest and sleep hygiene. Make sure that you teach about energy conservation strategies, such as the pacing and the planning of activities. So as told earlier, there's many persistent symptoms and they all might need rehabilitation. I'm not providing any detailed interventions today in this presentation for the other persistent symptoms due to limited time, but be aware that rehabilitation professionals will play a role in providing rehab for these other persistent symptoms as well. And then to conclude, I just want to share with you some key documents. Please be aware of the WHO website. In December this year, we will be publishing an updated version of the clinical management of COVID-19, and there will be a whole chapter, a revised chapter on the rehabilitation component. We have on the WHO website of Europe regional office, there's a patient leaflet that has been translated in many languages, which targets patients at home for the self-management of these persistent symptoms of COVID-19. So please check, so you can provide this leaflet to your patients when managing symptoms at home.
Doctor, you have 1 minute left.
I have 1 minute left. I'm finalizing now and concluding with the final slide. So on openwho.org, very soon as well, probably before the end of this year, we will have training modules for rehabilitation professionals all around the globe to be trained in the rehabilitation of the different impairment types that are reported in COVID-19. So this will be dealing what I have been saying today, but with much and many more details as of for now. Thank you very much, and have a good webinar.
Thank you, Dr. Wata again. And now we are going to next topic, which is going to be about the experience of medical rehabilitation centers, rehabilitation service during COVID-19 pandemic in Sultanate of Oman. And Dr. Amr Al-Toubi is going, inshallah, to speak about this topic. He is a speech and language pathologist. He is head of department medical rehabilitation in Royal Hospital. And actually, Royal Hospital was the first hospital in Oman dealing with the COVID-19 patients. So, Dr. Amr, welcome.
Assalamu alaikum. Good afternoon, everyone. If you can load the presentation, please. You have the presentation?
Dr. Amr, if you can share it from your laptop, it will be better, so you can control it yourself.
I'm using my iPad, so I don't have access in my computer. So if they...
Just a minute, Dr. Amr, we'll upload it.
Okay, thank you. So until they upload the presentation, I'll just give a brief introduction about my talk today. I will be talking about the experience of medical rehabilitation in Oman. I'm sure it will not be so different from other countries because I think we have been through the same pandemic all over the world. And it was so sudden and changeable that we had to rethink our management and our role so many times. And we all went through the same difficulties and challenges. So I will talk about the beginning of the pandemic in Oman and how did we prepare for it. And then when we started to getting admissions, the challenges we faced, and more importantly, the lessons we learned, because from every pandemic we should learn something that we should come from positive things out of the negative. So this is what I'm going to share now. Are we able to get the presentation?
Dr. Amr, can I interrupt you?
Yes.
For the participants, please, if somebody has any questions, put it in the chat, public chat, or you can send it direct to my chat. And the questions will be raised to the speakers at the end of the session, inshallah.
Thank you. Now we have the presentation on. Can we move to the next slide, please? So I will talk about the beginning. As all over the world, we heard about the beginning of the pandemic in China, and that was at the end of 2019. And since then, we were contemplating the role of medical rehabilitation. Are we involved? Do we have a role in this pandemic or not? So until we got the first reported cases in Oman, it was the February 2020, 2 cases were reported and they were linked to travel outside the country. And then by mid-March, things got a little bit serious and we faced with a suspension of routine appointments and OPD clinics. And there where we had to really think seriously, not just for COVID patients, but for our regular patients who needed intensive rehab, regular rehab, for emergency cases. At that time, we decided to accept some of the emergency cases that will really deteriorate of rehabilitation service is not delivered, or they could not access it. And some of those cases are already mentioned in the first presentation. So we had to write a list of cases or a list of pathologies that we really need to see as an emergency cases. And then we started the admissions. Royal Hospital was the first hospital that accommodate or received admitted COVID-19 patients. And then in April 2020, the first announced death of COVID-19 in Oman. So from then, from May until now, we have witnessed a sharp increase in number of infected patients as well as admitted patients. So we faced a number of challenges during this period from the end of 2019 till now. So the next slide will show you some of the challenges that we faced and how did we manage it as well. Can we go to the next slide, please? So some of the challenges, the medical rehabilitation role was really not clear at the beginning. And do we need to intervene in the acute stage, sub-acute stage, or just post-discharge? So we manage the post-discharge disabilities and weaknesses. So we had to do a bit of research on the role of medical rehabilitation in management of patients with the virus. Of course, the WHO has done a great job in updating the knowledge. So we used their website quite intensively. We also utilized other associations that were hit with the virus before Oman, and we started to identify the role of medical rehabilitation. So there was a conflict of opinions among the teams about the role of our rehabilitation because we faced with a lot of obstructions at that time. How many staff do we need in the wards of COVID-19? And then doctors were contemplating, do we really need to get involved at the beginning or when the patient is actually hit the respiratory distress? And from infection point of view, they were contemplating about, okay, what about the staff who will be seeing COVID-19? Can they come and mix with other staff? Can they see other patients? And they were trying to restrict staff who worked in the COVID wards from seeing other patients. So they would try to minimize the number of staff there. And then from the management point of view, because we had very limited resources at the beginning and we all went through the shortage of PPE at the beginning, and we had to deal with it quite, in a conservative way. So there was a big discussion about what type of PPE should we wear as a medical rehab profession, since we do a lot of aerosol techniques and we were exposed to secretions and we do hands-on assistant in mobilization, or when we test for swallowing or tracheostomy, So we are exposed and we are in direct contact with those patients. So the discussion was that we need the full coverall and full protection measures. And we ended up after a long discussion that yes, medical rehabilitation professionals, they need to be protected and they need to be wearing full coverall because they are in direct contact with the patients and they are performing aerosol techniques. There was a lot of mixed up as well between the role of different rehabilitation subspecialties. So physiotherapist, speech language pathologist, occupational therapist. So we get a mixed up referrals. You know, the physiotherapist will get a referral for assessing swallowing or for swallowing physiotherapy. And then we get referrals for weakness of limbs. So some of our doctors or our interns, they were not sure about, you know, what subspecialty, what is subspecialty role in the management of patients, in the management of cases. So this was an opportunity to actually clarify each subspecialty role in the management of COVID-19. So we developed the first protocol about the role of rehabilitation, and it was done to clarify the role of rehabilitation in management of patients with COVID-19. We also have done it to clarify the cases that should be referred and when should be referred. Can we go to the next slide? So one of the challenges, as I said, PPE shortage and the way of donning and doffing, because you know, it kept changing, and from protection control point of view, the sequencing, even the sequencing of donning and doffing kept changing, and we had to be up to date with the changes in infection control measures. So part of it is the availability, part of it was the donning and doffing, part of it is the changing, the designated changing areas for staff, because you need an area that you need to take for donning and doffing, and then we required an area that you can take a shower and you get out of there as clean as you can, and change your whole clothes before you leave the hospital. So with the communication with the management and with the concerned teams, we managed actually to sort out these small obstacles. We were hit with a sharp increase in number of admitted patients who required not only one intervention sessions, but sometimes up to 2 or 3 sessions within the day. So that's where we had to start the on-call services for COVID-19, because some of the patients that were needed to be seen in the morning, afternoon, and night, and those patients who were at danger of intubation. And some of those patients actually we managed with the hard work of the staff of medical rehabilitation to actually avoid intubation in some cases, especially those cases with pre-existing respiratory conditions. So we had some success stories that we already shared, and we prepared some case reports that we are hoping to get it published and share it to others. We were also hit with late referrals from medical teams, given the shortage on PPE. So whenever we finish our patients in the wards, sometimes because, you know, medical teams will do late rounds or documentation barriers in the ward, they will have to document outside. After the staff leave the COVID wards and they already done the doffing of the PPE, they were getting referrals. And to get another set of PPE was really a challenge, because at the beginning you have certain sets for certain days of the week. So to use an extra set, that means you are losing one staff because one set is already missing. So we managed that by discussing with the doctors that rehabilitation team and physiotherapists will do their own round, and they will identify the patients who need to be seen. Even if the referral is not initiated, and discuss with the doctors, then the doctors can initiate the referral. So we have overcome these obstacles by actually conducting a rehabilitation and physiotherapy rounds in those wards, identifying those patients who needs intervention early, and minimize the use of PPE, because we are in the same setting. We don't have to don and off every referral. And then we were faced with an early discharge of patients who needed further intervention from rehabilitation point of view because of bed crisis. So we had to really work on getting a treatment plan, getting an intervention plan, home program, or refer to other rehabilitation centers, whether they were private or in other hospitals, where they will accept some of these emergency cases, as services were suspended in most of the hospitals in Oman. Can we go to the next slide, please? So out of those challenges, we really learned a lot of things. So on positive note, it's not all bad. You know, we have learned how to communicate between medical teams, and we know this is the key point in success: communication, and sitting in the same table with all stakeholders, discussing matters and finding the best possible solutions with the available resources. So that was one of the key success things that we need to carry it over from this pandemic into and incorporate it regularly in our practice. Also, multidisciplinary team effort is required. You know, you cannot work alone, because sometimes you need to detach patients from bed oxygen support to portable oxygen support. Sometimes you need to mobilize patients with ventilators. So respiratory therapist, nursing, anesthetist is all there. During the proning and supination, the full team should be there to ensure safe proning or safe supination without causing a lot of laryngeal and tracheal injuries, because most of the time those patients are prone is ET tube is in place, and the danger of causing injuries and harm is there. So you need a full team with all multidisciplinary to actually get this work done successfully. And also we have learned that it's acceptable to do an overlap duties sometimes with other professions, because we were fully covered as medical rehab professionals, and our physiotherapists were doing a lot of chest physios, and they do secretions. So they were asked if they can, and they were asked and taught how to obtain ET swabs and sputum cultures. And Nasser in the next session will talk extensively about those overlap duties that we had to share with others. So to minimize the consumption of PPE, because already we are with the patients, so there's no need for other medical profession to put on a PPE just to get a swab or something. So we were able to minimize the PPE consumption, and as well as minimize the time and human resources to get some of these tests done. So we also learned that you need to seek help when you need it. Don't burn yourself or don't frustrate yourself. You know, you get support from everyone, and we Ministry of Health in Oman, as well as mental health associations, have developed the support teams to help medical staff as well as members of the community. So there is no shame in asking for help, whether it's psychological, physical, or even reassurance from others. And that kind of help and support helped reduce the frustration and burden when dealing with this pandemic. And that will take me to the next step, which is take all the support you can get. So other lessons is we learned how to work with limited resources and under a lot of pressure. Sometimes we had to minimize the number of staff entering there because of the limited PPE, or because we want to minimize exposure to decrease the level of possible cross-infection. So we focused on continuous improvement and development, and we find it's mandatory in such new pandemic. So each thing we found along the way, or we read about it, we try to document it, we try to share it with other hospitals and with other professionals that doing same work and receiving new COVID cases. And most importantly, you have to keep a positive attitude to overcome the frustration, because the situation was really frustrated. We were facing a lot of obstacles. We were under a lot of pressure, and keeping a positive attitude is key thing for success in dealing with this pandemic. And we took the opportunity actually to learn and improve our skills by conducting some research studies documenting clinical observation, releasing some short communication or brief communication about our findings. So this was a good opportunity for us as well to develop or further improve this skill, especially with the junior staff who had the chance to actually face this pandemic and to develop such skills. So the most important thing, we shared our success stories and we learned from our mistakes. So to avoid the mistakes and to actually give others who were facing the same situation a hope that there is a lot of success stories coming out of this pandemic. Can we go to the next slide, please? So in conclusion,
1 minute left.
this is my final slide anyway. So medical rehabilitation teams play a crucial role, not just in the management, sometimes in the prevention of escalating of symptoms in COVID-19 patients. So with the communication, multidisciplinary effort and support is a key success for facing such pandemics. Community and management support was really crucial, and it was effective for us as staff and medical healthcare providers, and sharing the experience across centers and from across within the same country or across centers from international centers have actually helped us to reduce the errors and improve the service provided. Thank you very much.
So thank you, Dr. Amr. It was a nice topic, and really you faced a lot of challenges, and we are proud of you at that period and all of the time, inshallah. Thank you, and thanks for your staff also. Now we are going to next topic. It's going to by Mr. Cherise. He is a senior physiotherapist. Also, he's a director and founder of White Band Private Physiotherapy Center in Greece. He's going to talk with us about the impact of COVID-19 pandemic on private rehabilitation center Greek experience. So welcome, Dr. Cherise.
Good evening. I hope you can all hear me. It's a pleasure to be here. What I'm going to talk about today is I'm going to talk about the Greek experience, and more specifically the impact of COVID-19 on private rehabilitation centers such as my own. I've separated my presentation into 4 stages, just how we've separated the stages of the COVID-19 pandemic, with the early stage, so pre-lockdown, the lockdown phase, which in Greece happened to be just under 2 months, the initial post-lockdown phase, and then the final phase, which is the return to new normal. In my presentation, I'm going to talk about the challenges and the opportunities that we faced for the continuous delivery of high quality care throughout these 4 phases. When it comes to the challenges, because my clinic is a manual therapy clinic and I'm a manual therapy specialist, the initial concern was the fact that I was going to have a lack of hands-on treatment. That was a huge concern, and it did put me into thoughts about to what extent it'd be worth keeping the clinic open or not if I was allowed to do that, allowed to do so by the government. A large challenge was also the patient fears.
Sorry to interrupt. Can you please share your slides to the screen because it doesn't appear here?
Oh, I should be sharing screen right now. Can you see it now?
Yeah, that's great. Thank you.
Sorry about that. I'll just go back to the initial bit. I just said that I'm going to separate my presentation into 4 stages, same way we kind of separate the COVID-19 pandemic. I'm going to separate it starting off with an early stage, so a bit before the lockdown phase, the second stage being the lockdown phase, which in Greece was just under 2 months, the third phase being the initial post-lockdown period, and the 4th and final stage being what we're in right now, which is when we're trying to return to a new normal. In this presentation, I'm going to talk about the challenges and opportunities that we face in order to deliver quality care throughout these 4 phases. When it comes to the challenges, we talked about the clinic being a manual therapy specializing center, so the lack of hands-on treatment was going to be a concern. Moving on, patients were actually fearful, and patients were bound to be fearful about leaving their house, leaving that safe space that they've created, and entering a new area which potentially isn't as safe as far as they're concerned. A big challenge was going to be the fact that we had to see one patient at a time. There could not be patients in a waiting area. There couldn't be an overlap between one patient and the next one. And it'd have to be just me, the therapist, and the patient one-on-one. A large challenge, which is an ongoing challenge right now, is the therapist's well-being. We talk about this when we talk about looking after our lower backs, for example. If we're not looking after ourselves, it's very difficult to look after a patient. This is especially the case right now. If I can't look after my own health with my protective equipment, with my hand hygiene, etc., it's very difficult, if not impossible, to continuously deliver quality care. A large challenge of the COVID-19 pandemic generally is the financial implication. Many people have either lost their jobs, have reduced hours, and generally have a decreased disposable income. What this means in the private sector means that potentially they have a decreased ability to have as many sessions as they potentially need, or they might not be able to come to physiotherapy at all because they simply can't afford it at this time. A final challenge, which is again is an ongoing one, are the government guidelines. The same way it's the case in all countries potentially right now. In Greece, the government makes decisions based on current cases and on the deaths associated with those cases. So it's constantly changing, constantly evolving. And as a private center, we need to be on the cusp of that and be able to make changes all the time. It's very easy just looking at those challenges to say it's not worth keeping the clinic open. Even if the government allows it, the challenges are huge. Why would I even go down that path? But it's really important from our point of view, and in my opinion, generally from healthcare and medical professionals, to be able to highlight the positive aspects, the opportunities, even in a crisis as severe and as global as this is today. So as far as the opportunities are concerned, it was a huge opportunity from even before the lockdown to display an element of the clinic being a safe space. That meant cleaning protocols early on. That meant that the patient would arrive and they would see that it was just them and just myself. So it was one-on-one with large session intervals between each sessions. It was also an opportunity to really develop treatment via online platforms such as Zoom. Most people have never heard of Zoom. Some people had a familiarity with Skype, for example, but it really was an opportunity to kind of set those principles for tele-rehab. Well, like we said in the previous kind of presentation, it is an opportunity to enhance our communication skills. It hasn't been easy, it is different, it does set new challenges, but we are able to develop a compassionate approach, potentially not just talking about the physical demands that patients have, but also looking at the psychological aspects, the stress aspects, the fact that potentially they've lost their job. That all comes into play when we talk about physiotherapy treatment nowadays. And this means that we are emphasizing a holistic care, so looking at the social, the psychosocial, as well as the physical aspects of their conditions. Thankfully, in Greece, for me at least, physiotherapy fell into the category of primary care, so we were allowed to remain open if we chose to do so. And the only thing that patients had to do was they had to send a specific text to allow them to go for their physiotherapy appointment. Moving on to the first phase, the early stages, so pre-lockdown preparation. What I did to many patients existing patients at least, I contacted them to make sure that they have an ergonomic setup of their home office. It's very different to work from home, very different to work in an office environment. That meant something like setting up the desk height, setting up where their laptop was going to be in relation to their new office chair, where everything was that they could reach or not. Another thing that we did is we preventatively sent activities for children, for parents, because the children were no longer going to be at school. We did send out lots of activity kind of booklets, developmental play activities for these children as a thing for them to do, which is also useful for their development. Lots of preventative exercises were assigned to patients, mainly pain, stiffness, postural relations. We also helped to gain a familiarity with the online platforms, showed people how to log into Zoom, showed them what a session on Zoom actually meant compared to a hands-on one-on-one treatment. We emphasized the enhanced cleaning protocols, what we talked about a safe working space. We talked about the kind of things that we did, the fact that they had to wear a mask, the fact that everything was deep cleaned after their session, really feeding into that safe working area or safe space for them to leave their house and come to here. It was compulsory for patients to pre-book, as it is normally, but there were no walk-ins allowed because everything had to be organized and the timescales had to be really, really well focused. And we did make sure that we booked patients' future sessions in advance. One of the reasons for that is obviously to maintain the attendance, but also it helped people actually have some form of routine. A common complaint that we saw in the COVID pandemic and for people working from home is that they lost a sense of time, what day it was, what time it was. We felt that if there actually was a few sessions in the coming weeks that were pre-booked already in their diary, they were able to accordingly make a few plans to kind of have a sense of time as things moved on. Moving into our lockdown phase, which in Greece was from the middle of March until early May, so quite a long period, patients had to send that specific text that we talked about for medical visits. And after the initial kind of shocking phase, as many people have, it was almost an opportunity to leave the house, to go to a safe space, to look after themselves, pains or conditions that they had. We didn't actually notice a decline in patient numbers, as was potentially expected and as was noticed by other clinics, either both in Greece or abroad. In fact, we saw an increase in new patient numbers, especially with patients related to work from home kind of conditions. So postural, cervical, thoracic stiffness, lower back issues, etc. As we said earlier, we had an increased gap between sessions to allow for that deep cleaning. And because my clinic has a large outdoor area, we actually saw people be attracted to that and start their physiotherapy, potentially things that were caused by working from home or physiotherapy demands that they had previously, because they knew they could do it in an outdoor area where the risk of infection and transmission would decrease. Moving on into the nature of the cases that we saw, we said we saw an increase in cervical kind of complications and the neurological aspects, tingling down the fingers, etc., that are often associated. We saw a decrease in traditional sport injuries. Obviously, people weren't doing their team sports, so we didn't see the kind of football, basketball injuries, etc., that we tend to see. But we did see sport injuries as people were exercising from home, either without a specialist or just following an online program, which often the technique is not ideal. We talked about the many postural implications that we had caused from home, maybe the desk height not being ideal, the laptop being slightly to the side and having quite a few hours in that period. These inappropriate working spaces really fed in to these kind of cervical, thoracic and lumbar issues. What we ended up finding out by lots of patients is that they tend to work more hours than they did from office while they were working from home. They almost felt that they were on their laptops, on their computers all day. There wasn't the 9 till 5 potentially that people do in an office environment. Straight after the lockdown, we saw numerous injuries caused by an initial overload, so a quick return to our old kind of lifestyle once the restrictions were lifted. I saw numerous pediatric patients come to the clinic because they rapidly returned to their very busy sporting programs after a period of relative inactivity. This was the same with athletes who unfortunately could either do very limited training or none at all. They returned to quite high intensity training, potentially even competing. So we had the relevant injuries come to the clinic because of that. There was actually a category of patients who had lockdown frustrations, we call. So it was a very frustrating time, both for people working during lockdown in their actual working environments or people working from home. This frustration led to people after lockdown trying new activities. There were patients who tried potentially extreme sports without any previous experience, which led to potential injuries and then coming to the clinic. Also, the kind of cervical issues that we talked about that people felt during that working from home period, it now was affecting them outside of the lockdown phase because they were driving places and they would feel that neurological symptom while driving, something that they hadn't got before the lockdown phase. The patients arriving here were often coming with more multiple and complex injuries, not just a simple cervical stiffness. Because of that lockdown phase, now it had become cervical stiffness with neurological complications, for example. In Greece generally, in this lockdown period, there was large emphasis on health and looking after oneself and the holistic approach to health. In our final phase, phase 4, it was a return to new normal. We tried to introduce more permanent changes to the ergonomic setup of people's homes. People are still working from home, most people. We're in a mini lockdown now, so people are returned to working from home. So really having those ergonomic setups being ideal to prevent future injuries from now on. We've also developed different ideas for creating a structure to help with the psychological implications of the COVID pandemic or of a lockdown phase, including the progressive and safe return to activity once the restrictions are lifted again. As a clinic, we managed to retain more patients who asked for long-term care to come in once or twice a week just to check on how they're doing their exercises, just to check on their spinal, for example, conditions, and just to keep an eye out on them as we move forward. There's also an enhanced interest in the preventative techniques and exercises, what a patient can do while they're at home, what a patient can do while they're relatively healthy, what a patient can do when they first get their first symptoms, spinal symptoms or upper limb or lower limb symptoms, for example. Patients really appreciated the holistic aspect that the clinic had and definitely the kind of approach that we had where we talked about their psychosocial aspect as well, not just straight away assessing range, and assessing pain levels, etc., as we potentially do in a traditional kind of setting.
Chris,
Finally, we know that there's a return to new normal, and the technological kind of advancements are here to stay, things like Zoom sessions. Where do we go from here? It's an opportunity for patients to really develop a deeper relationship with their therapists, talking about things other than their physical aspects, talking about their entire well-being. It's an opportunity to rethink how we live, how we spend our time, whether it's at work or our free time, our own well-being and our mental health. And it really has emphasized the holistic nature of physiotherapy, what physiotherapy can be. It doesn't have to be just the physical, it can be multiple aspects of your life. In conclusion, throughout this COVID-19 pandemic, communities have turned to medical and healthcare professionals to look for a good example almost. It's not only our duty, but also I think it's an honor to be able to respond to this calling from all our communities. As medical and healthcare professionals, we should strive to be the shining example that patients look up to, so that communities can truly and fearlessly look on us and lean on us from now on. Thank you very much. I appreciate the time, and I look forward to any questions you may have and the discussion period later on.
So thank you, Mr. Chris, and really it was also good experience during that time in private sector. And now we are going to next session, which will be presented by Mrs. Ala Al-Saeed. She is a senior specialist physiotherapist from Al-Adnan Hospital in Al-Kuwait. She's going to talk about the physiotherapy for critical ill COVID-19 patients in Al-Kuwait experience. So welcome, Mrs. Ala.
Assalamu alaikum. Good evening, everyone. This is Ala Saeed. It's my pleasure to participate in this webinar, and I'd like to thank the organization committee for inviting me. Let me first share my slides. Okay. Today, I'd like to share the experience of a team of physiotherapists with COVID-19 patients since the starting of the pandemic in Kuwait. And we will see together how can the physiotherapist help a patient with COVID-19, especially in the intensive care unit. Since the outbreak of coronavirus started, many people started to think whether physiotherapy can have a role on this patient or not. Is it very urgent, or do we have to be exposed to that fatal virus? And by the end of February, coronavirus reached Kuwait, and the Ministry of Health announced about the first cases infected with COVID-19 on 24th of February. When those patients started to deteriorate and they were admitted to the ICU, our consultant requested to have a physiotherapist in the COVID team because those patients might need our intervention. So we formed a team of physiotherapists within the COVID team. And since that time, we are trying to observe and understand the nature of the disease and how we can deal with it. Then we developed the guidelines of physiotherapy management of adult patients when COVID-19 is suspected or confirmed. And it's published in the Kuwait Physical Therapy Association, and you can find it in the site, and also in the WCBT. And inshallah, the new update will be published very soon. Just you can follow the KPTA site, and you will find inshallah the update very soon. Let me go very fast through the pathophysiology of the disease, because if we understand what is going on, we may know what is our role will be. Coronavirus gets into the respiratory system to attack the alveoli, which has two types of cell, type 1 pneumocyte, which is responsible for gas exchange, and type 2 pneumocyte, which is responsible for surfactant production, and which will decrease the surface tension within the alveoli and reduce collapse pressure. So it will avoid the alveolar collapse. When the virus will attack the alveoli, it will bind to a receptor, which is ACE2 receptor, in the type 2 pneumocyte. It will allow the virus to enter into the cell and make more copies, then release back into alveoli to start to infect more cells. This process can cause damage to type 2 pneumocyte, so it will gonna release the inflammatory mediators, and due to that, the neutrophil will be recruited to the site of the infection to destroy the infected cell, but unfortunately, type 1 and 2 pneumocyte will be destroyed also. This inflammatory process will cause damage to type 2 pneumocyte, as I said. Then the inflammatory mediator will stimulate the macrophages, which will, and what will macrophages will do? Sorry, let's go back to the slide. Yeah, what macrophages will do, it will secrete a specific cytokine, and it will cross the bloodstream and cause dilation of the smooth muscle and increase the capillary permeability. And now what will happen? When the permeability will increase, the plasma will start to leak into the interstitial spaces. So it will compress the alveoli, and some of the fluid will try to enter into the alveoli. That will technically cause a drown-out effect of the surfactant, which can cause collapse. So the gas exchange will decrease, and the work of breathing will increase, sure, because the patient will try to work harder to inhale as much as he can, not only to open up the collapse, but also he will breathe against the fluid in the interstitial spaces, which can cause ARDS. Now, in the center of alveoli, what we will have a collection of destroyed type 1 and 2 pneumocyte, fluid, some protein, macrophages, which will lead to consolidation, and this will alter the gas exchange, and the patient will present with cough. And it can be either moderate or severe. And when it will become severe, the inflammatory substance will travel to a different part of the body, leads to a systemic inflammatory response syndrome, which can lead to septic shock. Now, what is important for physiotherapy that we can get from the pathophysiology? The patient will present with atelectasis, consolidation, gas exchange, because of type 1 cell, it will be destroyed, alveolar collapse, or fluid in the interstitial spaces, or in the alveolar spaces also. Patient will have increased work of breathing, will have decreased mobility and functional ability also, especially if he's in ICU. Now, what is the main goal of physiotherapy? We have to improve or maintain the oxygen transport and the function of its supporting system. We have to reduce the work of breathing, to improve lung capacity, maximize functional recovery, and reduce multi-system complication. Now, for sure, before handling the patient, we have to assess and screen. What we have to check: the level of consciousness, the vital signs, inotropic support, the mode of ventilation and its parameters, ABGs, chest X-ray, cough, sputum, lab tests, underlying pathologies and contraindication to treatment, pre-admission mobility level, and the medical plan. and the assessment should be ongoing through each subsequent therapy session. Physiotherapy should be aware of the medical plan, for example, a patient for weaning, for extubation, for tracheostomy, for example. That's why the multidisciplinary team discussion is very important, even in screening. The primary goal following the patient screening is establishing a clinical picture of the patient status involving the indicators and indication and contraindication, considering we have to weigh the benefits against risk, then to relate the clinical findings to the patient problem. At this stage, the physiotherapy should have a clear idea of what is the potential problem that patient has, and regular discussion, as I said, is very important, and care plan must be modified according to the patient needs, tolerance, conditions, and therapeutic goals. This will improve and enhance the result. Meanwhile, it will minimize the risks. The main clinical indicator that we can find with the COVID-19 patient is sputum retention, consolidation, atelectasis, difficulty in clearing secretion, loss of lung volume, develop or risk of developing ICU-acquired weakness or functional decline. And maybe we have, if the patient on mechanical ventilator or he's on ECMO, we have to start earlier with him. Treating these problems may consequently improve other major problems such as hypercapnia, hypoxemia, and increase in work of breathing. Also, it can minimize invasive interventions such as intubation, bronchoscopy, and tracheostomy. First of all, we have to be very careful with the infection control prevention measures. It is very important to do regular hand hygiene and wear proper PPE. And it is very important to know and train on how to don and doff the PPE. Physiotherapy management commonly includes combination of techniques and strategies to meet the physiotherapy goals. So we have to choose according to the findings. We have to know whether the patient is in the acute or recovery stage and how. We can do that by discussion with the physician, by checking the X-ray, ABG's lab, inflammatory marker, and we have to know the whole picture. Because it is very essential for the physiotherapy procedure not to cause increase in stress and increased work of breathing in the acute phase, because this may increase the risk of respiratory distress. This is some treatment recommendation according to the main indicator that I talked about earlier, and you can find it in in our guidelines. And this is some of our treatment techniques. Some of our physiotherapy session, especially mobilization. It's applicable to do out of bed mobilization, standing, and marching on place while the patient in ICU. Early proning or self-proning, which is proning non-intubated patient, conscious patient. Previous studies suggested that prone position can increase PF ratio, especially if we combined it with non-invasive ventilation or high flow nasal cannula, and it reduced mortality and in moderate to severe ARDS patient. And sometimes it may avoid intubation. What is the benefit of early proning? Recruitment of previously collapsed alveoli in the posterior lungs, improved secretion management, which may further serve to prevent atelectasis and improve the recruitment of lung tissue. shifting of perfusion towards towards a healthier alveoli located in the anterior lung, thereby improve the ventilation perfusion matching. Decrease compression of the heart on the abdomen and the abdomen on the lung. Proning, it will improve oxygenation, but this benefit will be transient. That's why proning only may not be enough. We should combine it with other physiotherapy techniques. These two, I'll talk about two algorithms, which will be inshallah in the new guidelines. The first algorithm, which is COVID patient treatment. This decision
you have 2 minutes.
Level. Okay, sedation level and level of consciousness and patient response. If the patient is opening his eyes and obeying command not obeying commands, we have to start passive mobilization to maintain the range. If he starts to obey command, we have to engage him in active treatment. The other algorithm, it's how to take mobilization decision, which is according to the type of ventilation and a stage of the disease and work of breathing. In the acute stage, as I said, we should avoid the stress and increase work of breathing. And you can see that the treatment decision will divide it to 4 categories, which do not mobilize within patient normal, and don't increase level of mobility, or will increase ventilatory support, then we can progress in mobility, or normal progression in the mobility. As a summary, physiotherapy should be considered as a cornerstone in the comprehensive management of COVID-19 patient. Respiratory support can support the patient, while the physiotherapy intervention may accelerate the recovery. And the most important skill to physiotherapists to develop in the ICU is to recognize when to initiate, delay, progress, and terminate the treatment. And multidisciplinary team communication and collaboration is the main reason for the best outcome. Thank you.
So thank you, Ms. Salah, for your nice topic and to give us your Kuwait experience with COVID-19. Now we are going to go to UK. There is Dr. Hassan. He is family physician in primary and secondary setting National Health Services. He is going to talk about the journey of COVID-19 patients with National Health Service in the United Kingdom. So welcome, Dr. Hassan. Dr. Hassan, can you unmute?
Yeah, thank you. Can you hear me now?
Yeah, it's clear.
Okay, thank you. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, ladies and gentlemen. Thank you for inviting me to give a topic on patient's journey, COVID patient journey in the NHS UK. And I would like to point out that this is my impression of COVID as a senior clinician in the NHS UK, and not necessarily reflective of the national perspective. Let's begin with how did it start, the COVID pandemic in the UK. And on 31st of December 2019, we were informed by the WHO that there was a cluster of pneumonia cases from an unknown cause detected in Wuhan, China. This triggered the British populations in Wuhan to be flown back to UK and quarantined for a few weeks in the NHS hospital. And during the month of February, and this was the school holiday time, and a lot of holiday makers, and they were traveling to and fro Europe and other countries, and they were unsure about how to isolate and what kind of safety measures needs to take, because it was quite early at that time. Hence, there was slow trickle of cases throughout the February. The first death in the UK was reported on 5th of March. And in the month of March, there was a steady increase of cases coming to the NHS hospitals. And by the end of March, we were seeing a large number of COVID patients getting admitted, and in a critically ill patients. At one point of time, we were seeing about 1,200 deaths every day, and about 20,000 new cases were recorded every day. Hence, the UK government has thought of the national lockdown in the mid-March for a 12 weeks period. And after that, the cases come down during the month of June and July, and also the August. The schools started opening, and the business started functioning again normally. Now we are seeing the rapid rise of COVID cases in UK from the month of September. And at this moment of time, we are seeing about 25,000 cases in UK, and about 300 to 400 deaths per day. And now the government has put another lockdown for another 4 weeks, and we are not sure whether there will be another prolonged lockdown or not. Okay, let's talk about how this is impacted on the health services. Okay, NHS England were quick to develop rapid guidelines to deal with this pandemic. Hence, what happened was the number of elective surgeries were cancelled. Other health services such as cancer care, mental health, maternity care were all severely reduced in order to cater for the COVID patients. And also what happened was a lot of healthcare workers, the colleagues were tested positive and became ill. This also put an increased strain on the national health services. The hospital beds were freed up to take up for these COVID patients, and this put a lot of strain for other services. And at some point, we were getting about daily protocols and guidelines and to the healthcare professionals how to deal with this pandemic, because we're dealing with something which is unknown and which is unprecedented. Even the retired healthcare family practitioners and other consultants were requested to help with this management. Even the medical students from third year onwards were encouraged to help in the wards. A lot of charities were set up, especially the private charities, to provide PPE to the healthcare professionals and also to help the vulnerable people. At one point, we ran out of the PPE and we were in a very difficult situations. And this is the graph which shows the total number of cases and the total deaths. The yellow graph represents the number of cases. As you can see, from the month of April, it started at 5,000 cases, and it dipped down, come to almost normal in June, July, and now it is raising up to about 25,000 cases every day. And the red graph, which represents the death rate, if you can see there, in April, about 1,200 patients were dying each day, and then gradually come down. Then now it is about 300 to 400 cases every day. Hence, in the middle of the pandemic, the UK government, along with the NHS England, was planning to set up these Nightingale Hospital in order to cater for the ICU beds, because almost all the ICU beds were filled up throughout nationally, And this hospital was built in 9 days by the help of the military, and the healthcare practitioners, professionals were recruited to work in this hospital. And there are also such hospitals were planned across the other major cities such as Birmingham and Manchester. This is just an example of the Nightingale Hospital. On the right side, you see the overall plan. It's a one-way system. Patient enters and then discharged on the other side. And you see on the left-hand side, you see a typical ICU bed. Now let's talk about the patient journey, how these patients gets managed in the NHS services. Patients are encouraged to go online and report their symptoms, and then contact the 111 service. The 111 service is a national triage service, and it is initially patients call 111, and the telephone is taken up by the call handlers, the call technicians, and they will triage the call according to the severity. It's a heavily audited tool of complex algorithms which has been developed in the last 15 years. And based on the symptoms, if it is a mild symptoms, patients are given advice as per the NHS COVID protocol. The moderate patients are referred or passed on to the 111 clinicians, and which is National COVID Clinical Assessment Service. Then the severe patient with the shortness of breath or any chest pain, and they are they're referred to the ambulance service, which is a 999 service. Also, that can also be passed on to the clinicians for the further triage, and based on the severity, whether it's a moderate or severe, and the management is done accordingly. Also, we have a hot clinic in the community, where the patients can be told to self-present themselves if they need a face appointment. The priority was to manage them via telephone consultation or via the video consultations, and even the clinicians can do the electronic prescriptions, and if there is a need for it. Now let's talk about what's happening in the GP surgery. It's a family practice. The family physicians are not seeing patients basically because there's not much facility, and it's a small space area, and of the risk of infections. They are doing the telephone triage and the video consultation, and then manage them accordingly. If they need seeing face to face, they can be referred to the hot clinics, which is in the community, or if it's an emergency, they can be called an ambulance. Now, what happens in emergency department? The patient can present themselves two ways to the emergency department. Either they can self-report themselves, or they can call the 999 service, or the 111 service, which is the triage service. They can call a 999 for the patient as well. When they enter the emergency department, the triage nurses again assess the patient's symptoms and categorize into mild to moderate and severe symptoms. The mild and moderate symptoms, they passed on to the urgent care center, and severe symptoms, they get discharged and they get admitted to the emergency department. So what happens in emergency department? The patients gets investigated, such as the blood, chest X-ray, throat swab, CT scan, and ABG. And if the patients are stable enough, and they are discharged home with appropriate medications. If they're an unstable patient, they get admitted to the COVID wards. Again, the ED is completely divided into cold and hot areas, and there is no mix-up of any patients. And it's always, it's a one-way system. So what happens when the patients turn up in the urgent treatment center, where I play a main role? It's a frontline management of these patients. The patients can come into urgent treatment center in a few ways. One is they get an appointment from the 111 service, or they can walk in, or they get referred from the emergency department. Again, this is, we have two areas. One is hot areas and the cold areas, and the suspected COVID patients are kept in the isolation room, and they wait for the clinicians to see them. First, what happens is they do a telephone triage. They speak to the patients in the telephone, and they take a detailed history along with the social history and the risk factors. And then the clinicians enter the room with a full PPE and make a very quick and focused clinical examination to determine whether the patients are safe enough to be discharged home. The patient and the clinicians come out and then make another contact with the patients through the telephone. And based on that, they decided whether they get admitted to hospital if it is a severe patients with low oxygen levels, or they discharge home with medications. When they discharge home, they're advised to isolate themselves for 10 days along with their household or anybody in contact with them for 14 days. They're also referred on to the COVID management service, and which is run by the clinicians, and they are followed up every 48 hours until symptom-free. The main medication. Thank you.
2 minutes.
Thank you. The main medications we use in urgent treatment centers are antibiotics, and if you suspect there is a bacterial component, the hospital medicine, generally NHS, is dexamethasone and remdesivir. So there are also a lot of questions asked by these patients because they are quite apprehensive, and they do ask about vaccines for COVID, but still it's an early stage, and there's not enough. There are no vaccines available at the moment. Right. The testing for the COVID can happen in a few ways. One is the patients can get online, and they also go to the walk-in COVID clinics where they can get tested. The physio perspective, when I spoke to the physio, they face a lot of challenges, and they stop the session 48 hours after extubating. The main challenges they face is the desaturation with the shortness of breath, with needing oxygen, easy fatigability, and a lot of skin ulcers or pressure sores, perhaps due to combination of bed sores and the COVID as well. Then also they develop neuropathy, shoulder pains, brachial plexus injury, all due to these proning positions. When the patients are admitted to IT for more than 3 days, the letter is sent for the physio department to invite for the physio if needed. A lot of them, they find that they have anxiety, depression, neuropathy, and continuing loss of taste and smell. The NHS England has told the clinician they can do a remote confirmation of the death, either through video or telephone consultations with the help of the family members. And if there's nobody around with the patient, then the clinicians can do a home visit with hazmat suit. And what I find generally is patients are very apprehensive visiting these hospitals, and we see a lot of delayed diagnosis and misdiagnosis, especially of the cancer and other general medical problems. And I wanted to discuss some very interesting case scenarios, but due to lack of time and I'm able to do that, I'm sorry for that. I would like to mention a special thanks to Dr. Huda, HOD IT department, and Samia Al-Rasi, HOD department medical rehab services, and to Dr. Giri, my dear friend, senior faculty IT department. Thank you very much. Thank you all.
Okay, thank you, Dr. Hassan, to share us your experience from UK. And it looks like also different experience with the different management of this pandemic. Now we are back to Oman, exactly to Royal Hospital. And for this topic, it is very important aspect of this pandemic, and it's also affecting, as you know, all patients and medical professionals. So now we are welcoming a psychologist in Royal Hospital Sultanate of Oman. He is going to talk about psychological impact of the pandemic on medical professionals and patients. So welcome, Dr. Hashim.
Yes. Sorry.
Dr. Hashim.
Yes. Assalamu alaikum, everyone. Would like to thank the team and all the organizers for inviting me. Can I share my slides? Well, or is it with you guys? Or shall I? Can I share?
Please share the slides.
Okay. Can I share my slides?
Yes, you can, please.
Okay. All right. Can everyone see my slides?
Yeah, it's clear now, Victor. You can start.
All right, wonderful. Bismillah. Like I said, thank you, everyone. My name is Hashim Al-Hatmi. I am the psychologist at the Psychiatry Unit, Royal Hospital. It's a brand new service that has been established 2 years ago, and we look forward to push forward. This particular topic is going to be about psychological impact on patients as well as on medical professionals during the COVID-19. I must say, ladies and gentlemen, it has been a hectic 8 months and is going to continue to be hectic because it's not just about, me and my team dealing with patients who are attending the hospital or attending these psychiatric units or getting referrals from the different departments, but we are also looking at the frontliners. We're looking at all of our medical colleagues. We are getting calls on a daily basis and on a weekly basis by people who are stressed out, mentally exhausted and fatigued and just feel like, I don't know what else to do. So with regards to COVID phases, in the last couple of months since June, I've been talking to people, I've been delivering a number of webinars on a weekly basis, speaking about, one of the topics I've touched upon is that COVID-19 came in phases. The first phase was about stay home, stay safe, the global lockdown. After May and June had come in, many countries all around the world started to open up the doors, started to allow people to come back out of their houses. And, people are starting to, not necessarily mix, but keep with the necessary safety measures, keeping the distance 2 meters apart. Everyone needs to wear masks. And the question is, what is the new normal? Is this going to be the new way of living all around the world? So the second phase, I'm talking about here in Oman in particular, was about staying safe. That was the second phase. So people can come back to work slowly. Some people have gone back to work, done shifts, and others are still working from home where they can see that there's about a 70% plus of productivity. And there is an issue as to whether we should come back to work or not. So a lot of questions. We are now interacting and leaving our homes. How will life turn back to normal? What is the new normal? What exactly do we do now? Is this what's it going to be like when 2021 kicks in, the brand new year? We're seeing the coming of the vaccine. There are now more lockdowns coming. The UK didn't expect another lockdown, but yet they're going through it. Other parts of the globe are going through lockdowns or even curfews. We in Oman went through a second curfew. We're seeing a lot going on. You have the new academic year coming about. So we're going to get to the topic, but I'm just trying to get people to understand how the psychological impact has really affected everyone globally. So when we talk about COVID-19 and the mental health, we're seeing an increased rate or number of depression and anxiety cases. And this may vary, as we will get to in the next slide, as to whether it was people who had already an existing mental health condition versus those who started to develop due to COVID. Everyone has been affected in some shape or form. Public health and it's on both on a public level and a clinical level. Now, healthcare professionals, frontliners, and everyone in the healthcare industry has had an effect on this. They have been impacted psychologically and emotionally in a number of ways, and it is a struggle until today. We're seeing unexpected events. COVID was really unexpected. How in a fish market at Wuhan had something just kicked out and started to spread all over the globe. Many people thought this is just going to be just like H1N1, the swine flu that happened in 2009, and in the summertime with the heat, it will vanish. But unfortunately, we've not just completed the summertime, we've also completed autumn, and we're about to enter into winter, and it's still about. We'll get to that at the last slide. This future seems to be quite uncertain. What's going to happen? What are we going to do? What are we to expect? We're reaching to the end of the year, and everyone is going through their final year meetings and what have we done for the year, and let us plan for the upcoming year. Major losses globally. And when we say losses, we're not just talking about loss of loved ones. We're talking about financial losses. We're talking about economic losses. We're talking about losses in many aspects that have affected individuals, societies, communities, governments, and nations. The whole planet Earth has been facing a number of losses. Mental health. Let us start with the mental health of patients and the public and the public level. What we have here, ladies and gentlemen, and as you can see from my slides, there's a reason why. When I was choosing my slides today, I'll be very honest. I really found this picture really interesting because really we're on a voyage. We're really on a voyage. A voyage is a traveling on sea or on the sky. And what we can see in this voyage is that there's so many waves, unexpected waves. This pandemic is really a roller coaster. It's absolutely wavy, and it was unexpected. And you've got people now. How has it affected patients and the public? Either dealing with existing mental health conditions, such as people who are already experiencing and suffering from a mental illness, whether it be neurotic, anxiety and depression, or psychotic, such as schizophrenia and the likes of it. Then you have people who are developing high levels of stress, anxiety, low mood, OCD, trauma and grief and bereavement and what have you. It's too much. The stress is increasing. You have the family mental health. So you have people within your vicinity, within your families who are experiencing mental health, distress. You have the lockdown that has affected people. We feel locked down. In a lockdown, you feel like you're somewhat imprisoned. You can't come out, especially for people who don't have many resources. They live, let's say, in a flat compared to a home or a house where there might be a garden, there might be space. But if you're in a little flat, it might be very difficult on how you can manage the situation. The lockdown has really affected people. And that is why in the beginning of the lockdown globally in March and April, many mental health professionals, we have come together and come to give so many different advices, but targeting what can people do during the lockdown that can improve their mental health. It was challenging. It was not an easy task, but it is possible. Children and the elderly are, can be vulnerable. We've all heard about it. And looking after children, you're looking at the transmission, fear of the transmission. One thing that has been seen is that people are fearing of the disease coming onto them and it being transmitted within the family or within the household. You have the death and loss and grief and bereavement, the deaths and loss of family members who have had COVID or who have had other medical conditions or other medical diseases that had really affected and had made their immunity levels more poor. You have the loss of business, salary reductions, unemployment has been an increase, financial stresses and debts that people have been dealing with. As we come to the end of the year, what we've seen in the pandemic in the last number of months is studies that have looked into two different things that have related to mental health and the coronavirus. And one of them is the higher levels or the increase of sleep problems, insomnia, related to corona, what they now call coronasomnia. According to Dr. Alon Avidan, a neurologist at UCLA at the United States of America, he said that with COVID-19, we recognize that there is now an epidemic of sleep problems. It has boosted. And not only is there issues of sleep problems due to the fear of catching corona, but it has become already a routine for people to be sleeping late, to struggle with sleeping. It has become a routine over a number of months as we've been, as the lockdown had began in March 2020. An interesting study that was published in June this year by young men in Withoft about something called cyberchondria. Now, you have hypochondria, which is the old name of health anxiety, the fear of being diagnosed with an illness, to the point that you will start to look into all types of, you will do so many medical examinations. You'll do it at so many areas, so many hospitals or clinics, just to be reassured that you don't have a health condition or you don't have a medical illness, but you're not reassured. You want to make sure, and this is an anxiety related to health and illness. Now, what they've done is that they looked at the trait of health anxiety, cyberchondria, so that is the fear of catching coronavirus or being positive with coronavirus, and coping in the context of virus anxiety during the current COVID-19 pandemic. It has not yet been studied. So this is one of the first ever studies on this particular topic. Now, an online survey was conducted in the German general population, about 1,615 people. Participants had been recruited for the study. What they found was that the participants significantly reported increasing virus anxiety in the recent months. So the anxiety based on fearing of being positive for coronavirus. So what they found was the traits of health anxiety and cyberchondria were very closely related. And therefore, this is something new that we are seeing in the last 8 months, or 8 to 9 months. Mental health now for medical professions, they've been highly affected to the point that it was a sudden shock. All of a sudden, here comes Corona, COVID-19, SARS-2. And they have to be ready for what it is that they're about to face. It was about a sudden shock, quick preparations. You have everyone, not just the frontliners, the ones who are directly dealing with COVID patients, but the whole scope of the healthcare industry who have to be on standby for any of these emergencies. You have had people at a specialist level who had to do the work of a consultant. You have had people who are residents, medical residents, finishing their training in a specialist area, who were expected to be at the level of a specialist to complete their work because there was no time. You had to be prepared. You had to quickly be prepared and to go on and deal with the current situation, dealing with COVID patients, dealing with the current medical patients who are admitted. It was not easy. And until today, it is not an easy process. But it has made people prepared for bigger things, mental and physical exhaustion. People are working tirelessly. You've got fatigue, the fear of transmission, fear of family members, transmitting it into family members. I've had calls from, not just here in Muscat, but even outside Muscat. I've had calls from doctors saying that they're worried. Should I stay in a hotel or should I go back home? Because on one hand, I don't want to transmit this disease. I don't want to be the one transmitting anything to my family. But yet again, I do not want to overburden some of my elderly family members on my children that I have to take care of. So it's been very stressful for a number of them. Your fear of being positive with COVID. Now you're told to be quarantined. What's happening? Do I have it or do I not have it? What will my results look like? The loss of loved ones, those who are so dear to you, those who you did not expect. There are some people we expected that their time would come during this pandemic, but there are those who had suddenly and shockingly had passed away and were deceased during this pandemic. And it's hurtful in our hearts to lose the very dear people so close to us. Physical and social distancing. I can no longer be that close to certain people. We cannot have many meetings. We cannot, do the things that we used to do, pre-COVID. Once again, we come to the lockdowns. We come to the curfews. It is not easy at all. Children and the elderly, wanting to take your children out, and most of the malls are not allowing it. A lot of places are not allowing it. and it's very, very difficult. Moving to different wards, and one of the things I've seen is, for example, with the nurses, it's not been an easy experience being ready to shift to different wards, from health centers all the way to COVID wards and different medical wards. For many of them, it has been many, many years since they have last been to these wards. So it wasn't an easy experience. A lot of them were frightened. A lot of them were scared. A lot of them were absolutely frustrated and wanted to blame the authorities. But it
Dr. Hashim, you have 1 minute.
Have
1 minute, please.
Okay. A lot of them have been, all right, so summarizing this particular slide, it has not been easy, and a lot of us had to be on standby. Now, this is what people are looking for in the end of the day, ladies and gentlemen: resiliency and euphoria. Resiliency is the ability to deal with difficult situations, and it's about emotional strength. And euphoria, everyone's looking for pleasure and times of being happy. It is important that I would consider the last two slides. Recovery is important. We're talking about rehab. Rehab is about recovery. We are in need of more psychological services more than ever, such as the following. As I mentioned in this slide: psychological first aid, emotional intelligence, resiliency, positive psychology techniques, health behavior change for those who want to stay healthy and fit, and coping strategies, instilling hope, and learning how to be mindful, thinking about the now and the present. I would now like to end it with welcome to winter. The pandemic is still about, the vaccines are on their way. It's about surviving the rest of 2020. We have not seen something of the like since the Spanish flu in 1918, about 102 years ago. It's been crazy, but let us finally utilize the technology during the 21st century with telepsychology, telemedicine, mobile mental health that will help us at least engage with professionals during this time, and also let us use technology so that we can engage with our own loved ones wherever we are, from the east and the west. I ended with that, and I want to thank you all for listening. Thank you.
Thank you, Dr. Hashil Hatmi. This is like a discussion and break time. So if you have like any question, please, you are welcome to ask any of this participant. So you are welcome.
I think we'll leave the question after the break. We are going to have a break for 15 minutes. And once we finish the second session, then we'll gather all the questions and we'll ask the speakers. Thank you.
Hello everyone again. Welcome back. I hope that you guys had a lovely break. As we have discussed earlier, that we will be having a discussion of questions to be asked to Dr. Amr and Mr. Hashel together, if they can provide us with information if there are any occasions that staff from the rehabilitation department who are working with COVID-19 cases have been visiting the psychology department or psychology clinic. Also, this question to Dr. Amr, if there are any, if he had any challenges with regards to swapping the staff who are supposed to be working in the COVID units.
Thank you very much. The first part of the question, I think Hashel would be more appropriate to answer regarding psychological help from the medical rehabilitation department. In fact, we have distributed the psychological help number to staff, and I wanted it to be confidential with the psychologist, so I could see the frustration among some of our staff, and most importantly, the fear of transmitting the virus from the hospital to their homes and their beloved ones. There were a lot of concerns about in that regard. So I have personally asked Hashel to come actually and provide in-house psychological support and lectures for our staff, and I think that have helped a little bit. The second part of the question I didn't get. In challenges in swabbing our staff for COVID-19 virus, or we are taking the swab from patients. So what was it?
No, the question was about swapping the staff. I mean, the rotation of the staff on 2 weeks time. For example, as you have mentioned that you have 2 weeks the staff working in the COVID unit, then you change that rota into another one.
No, we don't actually do swabs, because at the beginning, to take a swab and you wait for the results, it takes at least 2 to 3 days. It wasn't as fast in the beginning. So if you don't have symptoms and you have been doing a safe practice in terms of full PPE, donning and doffing, we were not encouraged the staff to go and swab every time, because that psychological fear of just waiting for the results could cause a lot of psychological harm to the staff himself. But any staff who thinks that he was in high danger contact, either with patient or member of the community, we would directly contact the infection control and the staff clinic, and they would do the swab for them. At some point, in fact, we ended up losing a good number of staff in quarantine, because the rules has changed. Like, you need to quarantine yourself if you are in a positive contact. And when we realized that we are losing a good number of staff, we discussed with the infection control and with the management that it need to be a rethought. Swabs should be available to medical staff, those who are suspected to be having the virus, so we don't lose 30% or 40% of our staff in quarantine. So that was facilitated, but not mandatory to go for swab after 2 weeks of working in COVID.
That's great. Thank you, Dr. Amr. That's very clear.
You're welcome. You're welcome.
Now the question is to Mr. Chris Patsos from Greece. If he's available to answer the question.
Yes, absolutely.
Thank you. Mr. Chris, there was a question raised by the audience in terms that after the lockdown, the number of the cases has increased. And the problem is that it really caused, let's say, a load on the private sector here in the Sultanate. As an example, I will give you an example. They're complaining of the crowd that happened after the lockdown, because still some OPD units in the government hospitals are still closed, but the private sector was open. So in that issue, have you faced, like, how's the situation in Greece out there?
I mean, when it comes to the kind of situation after the lockdown in Greece was effective at decreasing the number of cases. Naturally, it's a very effective measure. I mean, the transmission is next to zero. It's minimal, so it is effective in that respect. But what the government and the community and the population generally did expect, they did expect a large increase in cases after the lockdown. What Greece tried to do is they tried to almost phase out the lockdown rather than suddenly eliminate all measures. So that did help to kind of keep control of the case increases after the lockdown phase. What that meant for the private sector, that did mean that in Greece, actually, the difference was that they all had the option to open. What happened in the private sector in order to spread that load was that almost all of the private clinics opened. So we were able to spread that backlog of patients which existed during the lockdown phase. During the lockdown phase, we had lots of people who did require physiotherapy, who did require rehabilitation. Some were very happy to go to the physical therapy clinics that were still open. Also, the public sectors were still open. However, it was the plan of the government from the get-go to include physiotherapy clinics in that primary care aspect, purposely, so that we didn't, after the lockdown finished, so that we didn't have this huge backlog of patients which no one would be able to control. Instead, in Greece, we had a steady flow of patients receiving their physiotherapy in private clinics, which are still open. And then once the lockdown phase was complete, those remaining patients who were still worried, they were able to go to other kind of clinics as well. So we didn't see that huge spike in physiotherapy cases, while we did gradually see a small increase as the tourism aspect opened as well in general COVID cases.
I apologize to interrupt you, Chris, because we'll have one more question. Thank you very much, Chris. We have a question to Sister Ala from Kuwait, who viewed their experience there in Kuwait. If she's present. I think Ala is not available right now, but we will postpone the question by the end of the session. Now I would like to present Mr. Hamad to continue with the program to the session 2.
Excuse me, I just have one question received from one of the participants from Kuwait. This is to Mr. Hashir Al-Hatmi. The question is about the availability of psychologists inside ICU. And do you have certain techniques to be used? Because in Kuwait, she's saying we don't see a psychologist inside the wards and ICU. Is it available in Oman hospitals? This is a question from one of the participants to Mr. Hashir, if he's there.
Sami, I think we will proceed with session 2 because it seems that he's not available right now.
Yeah, okay, we'll go on.
Welcome back, everyone. Hope you had a lovely break. Now let's introduce Mr. Mohammed Al-Yahyai, who is going to lead the season 2. Mohammed Yahya is a physiotherapist who got his BSc from Salford University in 1997. Now Mohammed is the head of Department of Medical Rehabilitation, Nuzwa Hospital from Oman. Mohammed, the mic.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Hamad, for inviting me to deliver the second session of this webinar. It was really, the first session was very well delivered, and we had good topics from various parts of the world. With this session, second session, we'll have 3 topics and 3 lectures. And the first lecture will be delivered by Dr. Abdullah Al-Mughebir from Kingdom of Saudi Arabia, and he's the assistant professor at Imam Abdurrahman bin Faisal University. So I would like, and he will talk about the telehealth or pulmonary rehabilitation, telerehabilitation benefits and barriers. It's quite a very good topic actually, and it's really interesting since the pulmonary rehabilitation needs a physical contact with the patients. And these topics really give us a really good outline, a good experience that we could benefit from it as rehabilitation providers. So please, I would like to welcome Dr. Abdullah for the lecture to give his topic. Dr. Abdullah.
Yes, Assalamu alaikum. Thanks all. I would like to thank the organizers for inviting me to this webinar, actually to this really important webinar and this really important and very critical time. So 1 second just to increase the voice. Hopefully my voice is clear, otherwise I will redo 1 second just to adjust the volume. Yes, it's adjusted. And the slides are showing, right?
Yes.
Okay. Assalamu alaikum again. Thank you so much for inviting me to this webinar. From the topic itself, tele-rehabilitation, I will start with this. Sure, I will cover benefits and barriers. And from the topic itself, tele-rehabilitation, I will introduce 2 concepts here, telehealth and tele-rehabilitation, and whether there is a difference or not. Then I will demonstrate some potential benefits of pulmonary or in general tele-rehabilitation. I will keep saying pulmonary because my background is respiratory care. Then I will demonstrate certain couple of clinical examples of implementing telehealth in actual life and how these examples were beneficial. At the end, I will present our data regarding acceptance of using tele-rehabilitation as measured on healthcare practitioners working in traditional pulmonary rehabilitation programs. I have been reading, writing, and publishing in topics related to telehealth and tele-rehabilitation, I mean, since 2009. So it was a quite 10 years. Nobody was aware that telehealth could be an essential someday. Fortunately and unfortunately, now the need is to the peak for such technologies, telehealth or tele-rehabilitation. Hopefully what I present today will give you actually, and this is the sad part of it. Yes, I was writing, publishing, everybody was writing and publishing about tele-rehabilitation, but there is no actual use with, let's say, big scale of programs. The available experiences are very small pilot studies, and we were not ready to do something in clinic, something applicable, or something that we could see in the clinic. So this is unfortunate, but I think and I believe that starting from these days, hopefully the COVID-19 will disappear. I mean, let's hope. And right after that, we will think about if something unfortunate happened in the future, and we'll be ready by something, whether it's telehealth or tele-rehabilitation. So I will start with this. So what's telehealth? Let's start with this. Telehealth can be defined as the use of telecommunication technologies to provide or receive healthcare services for patients at home. So healthcare provider in this case will be at the hospital or at the healthcare institute. Patients will be at home, and the communication will be done via any available telecommunication technologies, starting from smart TVs, iPads, laptops, smartwatches that are also very common nowadays, or even VR headsets as well could be used to deliver healthcare services from the healthcare institute to the patient at home. In this case, healthcare provider will be able to provide multiple clinical procedures, multiple tasks, usually similar to what's usually done in face-to-face. And this is all based on the type of tele-rehab or telehealth applications used, and the type of the procedure, of course. But the type of the telehealth technology will play a big role here, whether it's synchronous or asynchronous, and with the availability of with the availability of the internet and the reasonable price of the internet, the majority of the new programs are using synchronous technology, which is live chatting with their patients while they are at home. Everything could be done, starting from taking history, doing simple physical examination. I will talk about it later on. And the patient also could be monitored while doing, let's say, taking MDI medications, doing exercise, or taking vital signs. So this is the concept of telerehabilitation to start with. The second question, and I remember this picture a long time ago, and the question is still remaining: is it telehealth or telemedicine? Actually, WHO differentiates between the two, since telemedicine is for medical practices, and telehealth is for to support other healthcare services such as physiotherapy, respiratory care, or even medical education. For me, it's almost the same. Telehealth, telemedicine, telerehabilitation, all use telecommunication technology. So the technology, the method is the same. The difference here is the person who's delivering the service, whether he's a physician or a respiratory therapist. So we could start with that. And I really appreciate the speaker before me, or one of the questions were mentioned telepsychology. So we could join tele with any medical service, and it will be telepsychology or telenursing or tele-respiratory care as well. This will lead us to the second concept here, tele-rehabilitation, where we will join tele with rehabilitation. So the definition will be, the definition of telehealth will be the use of telecommunication technologies to support long-distance rehabilitation services. So it's almost identical picture as the previous one. We change the term. Healthcare provider in this case will be able to provide rehabilitation services, including breathing exercise sessions, upper and lower strengthening exercise sessions, mucus clearance technique sessions as well, could be done via video conferencing, for example, and the patient will be supervised while doing this. And this is the concept of tele-rehabilitation. That's clear from the definition. It will include all healthcare practitioners working in rehabilitation centers. Benefits of telerehabilitation. There are multiple reported benefits, clinical and non-clinical benefits. For the non-clinical, we could say telehealth or telerehab has the potential to decrease time and save time of the patient. So we will save the time of the patient going to the rehabilitation center, especially if it's outpatient clinic. Also, there is a potential to decrease the cost of transportation or the cost of conducting sessions inside the hospital. Of course, conducting similar sessions is available and doable at home will be cheaper. The third is that conducting telerehabilitation sessions will be more convenient for healthcare practitioners and patients, and this is all considered as non-clinical benefits. For the clinical benefits, we have multiple reports, clinical studies reported that using telerehabilitation was associated with less occurrence of symptoms, improvement in health-related quality of life and dyspnea level, more level of adherence. Patients will attend the program more frequently, and therefore they will be more adherent to the medical plan as well. And also it was associated with improved in physical exercises. The following slides, in the following slide, I will demonstrate a couple of examples. And the goal here is to demonstrate the potentials of telerehabilitation, and also to show the available technologies that could be used in the future for any telerehabilitation session. And we will notice how easy and simple sometimes is the technology. Yes, the term might be a little bit complicated, but by the end, at the end, it's very simple tools. In this case, in this example, this is a study done in 2017, and the goal was to assess effect of telerehabilitation on quality of life done in more than 400 participants. Participants in this study received monitoring devices such as pulse oximeter, blood pressure monitor, and weight scale. So they will do the measurement by themselves at home as trained in the hospital at the first session. These devices have the capability to be connected to the LCD screen or TV of the patient at home. So this is another easy, cheap way to do telerehabilitation. Patients will keep measuring their vital signs daily, and in case something raised the red flag for the healthcare provider at the hospital, the healthcare provider will read the results and send messages to the patient at home. And if needed, they will go further steps like visiting the patient at home to do further help. They found minimum benefits to quality of life in this study, and even though it's not superior, even though telerehabilitation in this case was not superior to the traditional rehabilitation, but being at the same level of traditional rehabilitation is good enough for me, because we will gain the non-clinical benefits in this case. Yeah, it's not supposed to, if we did not gain the clinical benefits, at least we'll receive the same clinical with less cost and time. And this is the idea here. Another older example, a little bit, it was done in 2012, and the idea here, or this case will show how simple we could go in telerehabilitation. In this case, they used Skype to provide weekly pursed breathing techniques for their patient. The number was 22 participants only. And the goal was to measure the level of social support and dyspnea level for those patients while doing pulmonary rehabilitation at home. So they did this on weekly basis, per slip breathing reinforcement session, because the first session was done face-to-face as a first learning session for the patients. And they found significant decrease in dyspnea. See, even with simple tool, even though I don't recommend using Skype, the regular Skype for medical usage, but I mean, there are versions of each app now. It's called medical version of that app. Let's say medical version of Skype or medical version of Zoom. And I mean, taking in consideration that it needs to be HIPAA compliant. Another recent example, 2020, and the goal here was to assess the benefits of supervised real-time telerehabilitation sessions. And they measured the effect on 6-minute walk test, quality of life and physical activity on 134 participants. And they did video conferencing to conduct strengthening muscle exercise and endurance exercise, in addition to educational sessions for the patients. They found statistically significant improvement with 6-minute walk test in both groups separately, but when they compared the
Dr. Abdullah, excuse me, 1 minute left.
Okay. Sorry for this. And another example with idiopathic pulmonary fibrosis, where they used a real physiotherapist or a virtual physiotherapist as well. Other examples used augmented reality glasses, which is something new, or virtual reality goggles as well, or programs. And these are also another two methods that could be done in pulmonary rehabilitation or any rehabilitation program. Going to the last point, telerehabilitation acceptance and barriers. In order to start a telerehabilitation program, we need to measure barriers before we go ahead. Why we need to measure barriers? I mean, to avoid the obstacles and to overcome the barriers and make the implementation more successful with high quality. And this is the idea. And this is what I did years ago. Searching the literature, we did not find any ready, valid, and reliable scale to measure acceptance of telerehabilitation. Therefore, we designed a scale specific for patients or for healthcare practitioners working in traditional programs and for patients attending traditional pulmonary rehabilitation program. We have used the two scales. We came up with two scales, one for healthcare practitioners and one for patients, specifically for telerehabilitation. And the first study just published a few months ago, and it's based on surveying 222 healthcare practitioners across the world with different specialties. What was interesting was the high percentage of healthcare practitioners who had positive intention to use telerehabilitation. So they were ready and have high acceptance rate toward using telerehabilitation in the future. But that was, I mean, the data collection was years ago. So what about now? So the percentage for sure will be more, and I'm planning to repeat the study again. The big factor was perceived usefulness. So, I mean, they believe that, and this is based on our study, they believe that telerehabilitation years ago is beneficial and has multiple potentials, high potentials for patients and for the healthcare practitioners. So they are willing to do it. So I'm assuming that nowadays the percentage will be higher, and they will present more belief on usefulness of telerehabilitation in the future. The other version is for patients, but we did not publish the data yet, but it's there, and the resources, if you would like to use any of them for your future usage. By using these scales, you will be able to identify the areas, the barriers, and where you could go to fix. Or the most important part is to identify the sample, whether this population is accepting the idea of telehealth or not. If not, don't waste the resources. Try to fix the program first, and then go to the next step. In conclusion, telehealth is promising. I know I'm exceeded the time. Sorry. Telerehabilitation is promising. We have multiple options in terms of technology, from basic video conferencing to augmented reality. Determining acceptance using the available scales will help to identify the barriers and overcome them, and to assure successful and long-term implementation. And of course, barriers are expected. Resources are here. Resources one, where you could find the 2 scales. And this is my book, Tele-Respiratory Home Care, which was published in 2009 or 10. And this is the second edition, 2015. Thank you all.
Thank you, Dr. Abdullah. It was really wonderful and fruitful lecture that all of us, I think, will benefit from. Thank you very much. Now I'd like to welcome for the second talk. It will be delivered by Mr. Nasser Al-Salemi and Ms. Al-Lawati from Royal Hospital, Oman. And they will give us a lecture about the level of involvement of rehabilitation team in the management of patients with COVID-19 in hospitals in Oman. Mr. Nasser Al-Salemi, he is a senior physiotherapist, of course, in the ICU. And Ms. Rawan Al-Lawati, she is speech and language pathologist from the Royal Hospital. First, I would like to welcome Mr. Nasser to give his talk, and then we'll go ahead with our. Mr. Nasser?
Thanks, Muhammad. Thanks for that. Thanks for the introduction. Good evening, everyone. It's a pleasure actually to share you today this webinar. We are going, inshallah, to share you our experience in dealing with COVID in Royal Hospital. Since the time is very limited, actually, we are going to do this presentation, me and Ms. Rawan Al-Lawati. We are going to talk about the level of involvement of rehabilitation team in the management of patients with COVID-19 in Oman hospitals. Mainly, I'm going to talk about our experience as a physiotherapist and speech and language pathologist working in Royal Hospital, and how we are acting with the COVID patients. Starting with the rehabilitation team whom are working in COVID ICU. This is our team during the duty. I'm going to talk about the physiotherapy role in COVID-19. Actually, I have split it in 3 parts. I'm going to talk first about the cardiopulmonary interventions. Before talking about the cardiopulmonary interventions, just I would like to highlight that we are categorizing our COVID patients in 2 parts, or we have 2 different categories of wards where we are admitting the COVID-19 patients. The category 1, which is the less critical patients, they are admitted in the ambulatory ward, and the critical patients, they are getting admitted in the critical ward or in the ICU unit. We do act in both sides actually. That's why in terms of cardiopulmonary interventions, I'm going to talk about what we are doing for the non-ventilated patient and what we are doing for the ventilated patient. Non-ventilated patient actually, whom they'll be usually admitted in the ambulatory ward, we do help them how to manage their breath well by breathing exercises, active cycle of breathing exercises, by the PEP exercises. We are teaching them some of the relaxation technique and the techniques they are using to consume their energy while they are doing their daily life activities. This is what we are doing for the patient who are getting admitted in the ambulatory ward. Talking about the other part of patients who are admitted in the critical area, actually, usually they'll be ventilated. So what we are doing as a physiotherapist for ventilated patients, we are responsible actually in terms of cardiopulmonary side for airway clearance. We are achieving this goal by doing the different techniques of chest physiotherapy, percussion, vibrations, positioning, postural drainage, followed by airway suctioning with its different types actually. This is if the patient is in critical area. Going to the second point actually, which is the musculoskeletal interventions. Usually the patients who are getting admitted in ICU side, they be associated with severe weakness. As the studies shows that patients who are admitted and sedated in ICU, usually they tend to lose 3% of their muscle power per day, as per some of the studies. So most of the patients actually, they are getting intubated from 1 week up to 4 or 5 weeks, some of them. So the weakness will be varied and different from one to another. So here physiotherapists are playing a great role actually, helping those patients to get back into life. This is a short video showing that what we are doing with the patient there, which is the last stage before discharge, going to the gait training. But if we are going into the depth actually, we are doing a part of musculoskeletal when the patient is discharged, when the patient is intubated and sedated. We do the passive exercises on bed. We do positioning with help of the staff nurses actually to avoid DVT, to avoid bed sores, to avoid stiffness. Moving to the second part of musculoskeletal intervention, when they start weaning off and start holding the sedations and extubating the patient, we will start according to the duration that patient actually spent in the critical area. We will do the assessment. What things he lost, we are going to build up our own plan according to the available assessment. If he lost, for example, let us say that the balance is lost, we have to retrain the patient again, the balance, sitting, standing, and strengthening exercises. Ending up with the gait training. Once we achieve all of those goals and they will wean successfully the patient, ending up with the part of keeping the patient in room air without any oxygenation support, we usually send the patient home with the daily life activities and home program. We do have a channel of contact with the patient either through the phone or by WhatsApp actually. We do give and guide them for some exercises. They usually came up daily with some of the queries and questions about what exercise they should perform, what exercise they should avoid actually in terms of the intensity of the exercise they used to ask us. So we keep actually in touch with the patient even if they are at home. Some of the initiatives, things actually we are doing, since it's a pandemic, actually we were actually forced to work hand by hand with the other allied healthcare workers and the doctors. So we are doing positioning as Ms. Ala in her presentation explain in detail the benefits of proning and supining patients in between in critical area. So we do help the staff nurses and the doctors who are working there in positioning of the patient, as well as collection of ETT sample, endotracheal secretion samples. We do help the staff nurses in collecting that and sending it. So here is one of the photos, the picture showing how we are working together in terms of positioning the patients. Some of the findings, like since it's a pandemic, since it's new things we are working with, I would like to highlight some of the findings we find while we are working with COVID patients. The first point, which is very important point, the silent hypoxia or desaturation with mobilization. We tend to find that patient after getting extubated step down from critical area to the ambulatory side. We will keep doing some of the exercises, on-bed exercises, edge of the bed exercises, and out of bed exercises. What we have found that the patients or some of the patients are desaturating during exercises. So actually we have discussed with the doctor, we discussed with our in charges, and then we will conclude that we better get monitors or this one, saturation probes, which is portable. So we can carry or we can use while we are ambulating patient, making sure that the patient is not desaturating during the exercise. In case the patient is desaturating, actually, we should provide the patient with some rest. If rest is not working, we have to seek help from the doctors to initiate some oxygenation support. Also, one of the
Nasser, time for Rawan. Time, you should leave time for Rawan.
The last point, one of the things actually we have found that the frequency or increasing the frequency of physiotherapy is preventing intubation in such cases, COVID-19. Now I'll give the scope to Rawan to talk about the speech and language therapy service.
Hello, everybody. Am I audible to everybody? Okay, so I would like to start my presentation and my talk with a personal experience about COVID. The first time I had a patient suffered from COVID, and it was my turn to see that patient. I can remember a video that one of my colleagues as a physiotherapist did, an educational one about donning and doffing PPE. And that was the whole thing that I was thinking about. How am I going to don and doff my PPE? So sharing that experience with you, I want to tell you that sometimes our limitations or sometimes our weaknesses are not related to our care to our patient, but sometimes they're related to us. So for me, that was one of the things. And with practice, I got over the idea and I learned how to properly don and doff. So that was one limitation. And I think a lot of you had personal limitations when dealing with COVID. That's it. Next slide, please. So in this talk, I'll talk about three different topics. I'll just highlight on a general role of speech language and pathology. I'll talk about the services we provide at the Royal Hospital, and then how these services have carried on or have changed during COVID-19. Next slide, please. So according to the American Speech Language and Hearing Association, speech language pathologists work to prevent, assess, diagnose, and treat speech, language communication, social communication, cognitive communication, and swallowing disorders in both children and adults. Next slide, please. At the Royal Hospital setting is more of an acute medical setting. So we deal a lot with patients suffering from dysphagia, dysphonia, and we take over the tracheostomy care, which is related to the patient. Next slide, please. So what do we do with COVID-19 patients, or how has our services changed during COVID-19 patients? First thing I would like to mention is as speech language pathologists, we don't usually work with intubated, unawake, unconscious patients. So our main role comes post-extubation. Post-extubation, I could divide our patients and the scope of patients that we have seen during COVID-19, they are divided into two. Patients who are successfully extubated, either successfully extubated to hopefully room air, most likely they're not room air, but they're more on an oxygen support. And the majority of patients that we see are those who fail extubation, and consequently, due to that, they are tracheostomized and connected to a ventilator through that tracheostomy. So I'll mainly talk about patients with tracheostomy and what we do with them during their hospital stay. So first of all, we work with a vast majority of a multidisciplinary team from the respiratory therapists, nurses, and doctors to work together with the aim of weaning that person from the ventilator support and decreasing that. With that aim, we try to work, and our main goal is to try to regain swallowing functions and communication skills. Working on regaining swallowing functions, trying to wean patients from tubes such as nasal NGT tubes, OGT, or other feeding tubes. We start from the beginning on working, restoring those oral muscles that have been weakened or have deteriorated during a patient's ICU stay or intubation time. So we start from day one, working on those muscles, starting patient on sips of water, and then building upon the patient's diet from water up to, let's say, liquid diet, soft diet, and this build on. One of my favorite parts and one of my best time with patients, and I have fitted speech valves a million of times maybe by now, but it is still one of those things that still give me butterflies when I do fit a patient with speech valve. a lot of patients, due to the anatomical restriction of the tracheostomy, their voice is not there. Patients and their family have the idea that, oh, I've lost my voice, or due to the intubation or my long stay in the hospital, my voice is not there. They don't have that idea that it's just the tracheostomy, and that anatomical obstruction is not having, is the block to the speech or voice. So once the first time we deflate a cuff of a patient, we manually occlude, and the patient and his family hear their voice, they are really happy, they're really thrilled. So these are one of the best experiences that I've had. These are one of the best times we have seen patients with. So speech valve fitting, if a patient fits the criteria to do that, and this is one of like the biggest highlights that I have seen when we work with tracheostomy patients, because once they hear their voice back, once they know that their voice is still there, their progress, their prognosis, the improvement happens really fast. Other than that, we start with patient from day one after tracheostomy, and we work with that patient during the whole period of time till we prepare a patient for decannulation if they fit the criteria. So that's what we mainly do when patients are admitted. And even through admission, we try to prepare the patient for discharge.
Rawan, 1 minute left.
Okay, for rehabilitation. So we try to help patients regain their voice quality. If there was no neurological deficit that occurred during the patient's stay, we work on improving cognitive and communication skills that have been deteriorated due to the long hospital stay. But if there's a neurological deficit that's improved, we also work on improving the cognition and communication skills. One of the things that we have done during COVID is due to, as Dr. Amr said, our OPD clinics have been stopped during COVID. So we worked on a tele-rehabilitation method where we started following up our regular patients, our patients who are from a long time with us through the phone using a tele-rehabilitation method. I would like to summarize my presentation by saying that our role as speech language pathologists is still developing. Our role as what we do with COVID-19 patients is still developing. There are a lot of complications that occur to patients due to COVID-19 that we're still learning a lot from, and we're still researching about, and we hope to either prevent those complications or work to regain the functions that have been lost. There's still not known how, to what extent does COVID-19 affect speech and swallowing, and we're still learning and working with patients. So I hope this was beneficial to a lot of you. At least now, if you have a patient with any swallowing or speech deficits, you know who to seek help from and to who to refer your patient. Thank you very much.
Thank you, Rawan. Thank you, Nasser, for a wonderful speech that you delivered to us. And jointly done by physiotherapists and speech therapy. Wonderful. And congratulations for all of your efforts at the Royal Hospital. Now, for the last session, I would like to welcome Lashmi Sakar, who is an occupational therapist, and Ms. Zakia Nobi, head of the Prosthetic and Orthotics Department at Royal Hospital. Jointly, both of them, they will give us a topic about the medical rehabilitation services profession during the pandemic. So we'll start with Ms. Lakshmi. Ms. Lakshmi, please.
Yeah, thank you so much. I'm just trying to share my screen. Just a minute. Is that visible to everybody? Am I audible?
Yes, it is audible. Clear. This is clear.
A wonderful good evening to all of you. I'm privileged and honored to be given this platform to talk about our experience during COVID-19, the pandemic, and the emergence of all of a sudden an extraordinary situation, and how we have coped and will be coping through still. My talk today is about how occupational therapy department at Khola Hospital, one of the tertiary care hospitals, had coped with the situation, how we have changed the protocols time and again, and have continued our services. We have actually not terminated or stopped our services all through, but we had to make a lot of changes and accommodations. I'll be talking about those. I'm just briefing about what is occupational therapy. We deal with coming back to normal life, gaining maximum independence possible in life. And our main aim and goal is recovering the cognitive areas and the sensory areas. So as occupational therapists, we are very worried, and we focus more on our clients' complete well-being. It has to be emotional, it has to be physical, it has to be cognitive. All areas have to be balanced. And that's what had shaken up during this pandemic. Our well-being was questioned. These are some of the pictures of our activities in our department. And this particular picture is when we had planned a gardening activity, planting a tree of hope by children of having autism during the World Occupational Therapy Day last year. I summarize my talk as, with the starting months, that is, we all know when it had just hit us, was the early days of February. January, February, March, these are the months. We had faced the collective vulnerability. Occupational therapists are very well versed with helping with emotions and rehabilitative needs of our clients. But then this pandemic was very new for all of us. None of us had any framework for what was going to happen and how we had to handle it. We all started realizing very soon that we could only tide the situation by caring and coping by caring for each other. First of all, it had to be the staff itself. We had to keep ourselves safe, available for our clients mentally and physically. Déjà vu was the next experience. We had read in history 100 years ago, similar situations happened, but none of us had real clue how it was. And today, because things have changed a lot, we had one great advantage of technology. So having these situations in mind, occupational therapy at Khola Hospital went ahead. During the midstream, that is when we were in the pandemic, but we had to deal. We did not actually plan to terminate our services as such. And we made provisions as to how to continue with these client care. So we had to set our priorities. We had to set as to which clients we had to select to work on, and which we could, in a very unofficial and not a very typical way, but we had managed to start teletherapy for our clients, especially the pediatric population. The theme of Occupational Therapy 2020 during the pandemic has been fixed for reimagine doing. Occupational therapy is all about instilling doing into our clients. And this year specifically, we as therapists and we as community had to reimagine all over again, revisit our protocols and strategies to work in a near normal way all over again. And this was a new normal for all of us. So we were setting new strategies and plans. The first thing, information we had got was to close the OPDs. But then, unfortunately, we have certain OPDs very closely connected to the hand clinics, the surgical clinics, the orthopedic clinics, and which were partially running. And so it meant that we could not fully close our OPDs, because splinting is one very big area for occupational therapists, and we had to continue that service because people had a lot of conditions where amputations were there, revascularization of nerves were there. There was, K-wire fixations. So when these wires are removed, or when amputations are there, desensitizations and splinting was an emergency service which we had to render. So we never managed to close that. That was continuously happening. So what had to happen was we had to divide our staff into 2 groups for a backup group as well. And then most of us were covering the inpatients because patients who are already admitted, their services could not stop. So most of us had to cater the inpatients. And the outpatients, we divided into the some of the emergency cases where we had to still continue calling them on an OPD basis. But the pediatric cases, because of high level of risk, we had to definitely shift them to online therapy sessions, the teletherapies. And so interactive sessions started getting virtual. It was an experiment for all of us, but we strive to build strong interactions between us, ourselves, the multidisciplinary team, created a feeling of well-being, supported each other, and went ahead with new protocols. Tiding over this new normal, our strategies changed, like the splinting as well. The splinting cases which were not urgent, we had started seeing them on appointment basis. Appointments were placed far off so that patients don't overcrowd the place. And we see to it that we get time in between patients to sanitize the place. And we also see to it that rooms are kept vacant for around 15-20 minutes after a patient leaves. So we ensured that we ourselves, the staff, as well as our clients, are safe. Then spacing between patient slots was also done. Pediatric cases who wanted to visit us, because a lot of them opted not to visit and were continuously calling us on phones, and we were guiding them on video calls. And because we had a limitation in our department that we did not have the provision of internet, and therefore we had to extend our services and our reach during evenings and sometimes even late nights. We were always available for our clients. Parents used to call anytime because we all know this is a very, very stressful situation. So we were attending calls and exchanging videos. I was even supporting parents by sending them videos as to continue with fine motor skills, gross motor skills, and some vocational activities for the kids. And parents as well were, when there were a lot of behavioral issues because of social distancing and not moving out and a lot of protective equipment to be worn. So children had a lot of behavioral issues, are still having. So parents had those issues. I used to tell them to film some videos and send over to watch the behavior more closely and give them options and ideas as to how to tackle them at home. So this kind of teletherapy was continuously going on, and we were trying to
excuse me, Lashmi, leave time for Zakiya, please.
Yeah, and then 2 minutes more. So the teletherapy continued through home programming and receiving videos. So the uncompromised areas at a whole was the inpatient department, stroke and all the neurological and surgical cases, splinting, and NICU babies were never left. We were always attending those situations. Now the present scenario is we are trying to restore the OPD services completely, and patient conditions after we are expecting, and we are also started getting a lot of behavioral issues in our pediatric cases. So the expectancies of the outcome of the pandemic is that we'll see a lot of new cases emerging, and we have to make protocols and strategies to tide over these situations. So my perspective is that the future began in March, and we are going in a phase of betterment and learning new technology and using the situation as an opportunity to create a new story of hope, survival, and resilience. This is a beautiful team at Kola Hospital, and that's a very big thank you with a lot of hopes depicted by this hopeful tree. Thank you.
Thank you, Lashmi. Thank you for your lecture. It's really wonderful. Thank you. Now time for Mrs. Zakiya.
Yes.
For Mrs. Zakiya Al-Noubi, Head of Prosthetic and Orthotics Unit Department at the hospital. Zakiya, can you hear us?
Yes, I can. Yeah, I can hear you. Can you hear me?
Yeah, we can hear you very well.
Yeah.
Deliver your speech.
Yeah, thank you very much for inviting me. And actually, first, I will talk about what is prosthetic and orthotic. Actually, can you change the slide, please? Can I control this? Can I download mine? Go back. Sorry.
Yeah, I'm going.
Muhammad, can I download mine? Can I share screen my presentation? Because it's easy for me to control it. Can you give me this? Can I share my presentation?
Yeah, you can present it, but I'm not there in the control room.
I cannot control the mouse. Anyway,
Okay,
I was
Zakia
Zakia, just
downloaded
give me an
fast.
instruction to for the next, and I'll change. Don't worry.
Okay. So prosthetic is artificial devices. We do it for patients who lost part of their body. So in our department, we are doing prosthetic and orthotic. So our department didn't close during the pandemic. So we open all the time because our patient is very unique. We cannot stop the surface in the department. The second part is orthotic. Can you change, please? Orthotic, it is like our devices for patients who have their leg, but their muscles weakness they have some deformity. So we do for them some braces. Can you change? Change, please. Wallahi, difficult not controlling. So we have different type of orthosis. Go back, also change again. So our orthotic, it is different type, can be upper limb, lower limb, and also we have spinal, upper limb. Next, please. Also spinal orthosis. So we all manufacture in our department. So this kind of patients, we cannot stop the surface. So because of that, we need to see them all the time. So we cannot tell them we cannot open the surface. So we open inpatient and also outpatient. So say next slide, please. The types of patient visit us: CP, post-polio, fractures, spinal bifida, low back pain and congenital deformity, amputation with history of diabetic, trauma, and also cancer. So this type of patients is very important to see them all the time. We cannot stop the surface outpatient or inpatients. So we keep our surface open, but we do some protocols. Next slide, please. Inpatients and outpatients as well. So we have to continue, as I said, our clinic, but we have to be very safe to not affecting our patients and also our colleagues and families. Next slide. Clinic and staff. So what we have to preparing of our clinic and staff. So we have to call our patients before before their appointment. So we see if we can see them same day or next day, or if we can assist them through the phone and WhatsApp. If not, we can give them appointment and come face-to-face clinic. The old people who have need repair their braces, they can send it with friend and relative. If our staff have a fever or cough, not asking them not to come and go to the staff clinic. Reduce our staff number from 30, then 70, then 2 shifts we done. So it starts, we make it like 30% of the staff to come. Some of the staff, we keep them on call. Then the second, after April, we start another shift. Can you go back? Go next. Then we increase the number of the staff because we put numbers. We see how many patients every day, every week. Then we decide if we're increasing the staff or decrease. So not keeping all the staff on the same time. So sometime after a while, we try to done 2 shifts. Morning shift from morning to 1 o'clock, then second shift from 12:30 to 6 o'clock. So that maintaining not all the staff in the same building because our building is very small. Next slide. This is our statistics. 2017 up to 2019, the number of visits of the patient increasing. But in 2020 up to September 2020, we saw 4,003 patients, 937 from Khawla Hospital itself, others from the region. And we issue about 2,133 orthotic and 181 prosthetic in up to 20 of September. Also, our aim is to reduce the number of the patient appointment, but still we have to see them other type, and only the amputation or urgent patients, and others we can call through WhatsApp. So we have to define the patient, what is urgent, what is not urgent. But still, our hospital is a trauma hospital, so we have to see the burns unit. We give them different type of abduction braces, pressure garment also. The post-operative patients, amputations. So we have to see all the most of trauma patient in Khawla Hospital. So that's why we couldn't close either our outpatient or inpatient. So to prepare our clinic, so everyone entering to the building, all staffs need to wear face mask and providing to the department an automatic thermometer. It is in our department, all staff need to check their temperature, also anyone entering the building. Next slide, please. Make sure all seats are about 2 meters apart. So we keep some patients waiting in the car outside if it's crowded, then we can call them by their name according to the queue. So we don't keep our clinic is full of people. All staff must wash or sanitize their hand every time after each patient. And next, please. Also, all the rooms should be clean, and before and after each patient, we have to clean and change the tissue, change everything. Next. Use single-use tape measurement also.
The key at time.
Okay, walking in prosthetic and orthotic. Our devices, we have to clean all the devices between us, because the device went into the department, we have to clean. Then after clean, sanitize it and send it to the workshop for repair, send it back before giving to the patient. Also, we have to clean it. So next slide, please.
1 minute, the key, 1 minute.
Yeah. Okay, so we have to, can you be fast, Lakshmi? Can you open it all? Yeah. So our workshop should be organized and clean, nothing in the table. More tools should be cleaned before and after use. Next slide, please. Because I'm not controlling, that's why, sorry. So our department is really small building, so that's why we keep patient waiting in the car. Go back, sorry, your first office. So we are aware if any patients that has diagnosed with COVID, we can see them in the SHIPA system. Get training for child feeding patients. I'm really concerned. Our team work in the hospital, and also it's very, very important, the teamwork. Plus, we design mask holder. We're recycling our plastic, and we make about 2,000 mask holder, and we share it to all our staff in hospital, also the other institute. Teamwork is the key for development, and this is our key for good communications and good teamwork. This is the future, and this is the key for any development. Thank you very much. Sorry, because I'm not controlling the mouse, it's so difficult.
No, it's okay. Thank you for your wonderful lecture. And thank you, Lakshmi, also, for both of you. There's a question actually for Mr. Nasser Al-Salim. Nasser?
Yes, Muhammad.
Can you hear?
Yes.
Yeah. There's a question regarding the number that you use. How many physiotherapy sessions should be done for COVID-19 patient in ICU? And if there is any guideline regarding this. This is a question raised by one of the participants.
So, Muhammad, it depends on the patient condition actually. Usually, if the patient is very sick and critical, you cannot spend more than 1 session. But if the patient is showing an improvement, weaning out of ventilator started, you can increase the intensity, which is going to accelerate the weaning process and accelerate the early discharge as well.
May I ask a question, Nasser? The time of the cooperation between you and the anesthetist team, do they involve you in around like for the team who is working with the ICU patient? Do they involve you with the management also of the patients, or is it have to do around?
Yes. Actually, we are doing sometimes around with the doctor, and they do ask us what is our point, or what would we feel about extubating a patient or about starting weaning a patient. They will ask about the quantity of the secretions coming out. So they usually ask us about those points.
And do they involve also speech therapists along with you?
Yeah, sure. Usually when the patient is tracheostomized, actually, that's the time they will contact the speech therapist. And Rawan can elaborate more on this answer.
He with us?
Yes, regarding patients who are tracheostomized, once they are awake, conscious, not oriented, but at least awake, you can fully assess them. We start doing our assessment and our management care. Our main goal with tracheostomy patients is to decannulate them. So we start with them from day one, work with them, build upon their care. If they're on NGT or any other tube feeding, try to work on swallowing functions and regaining that. So yes, we really do work a lot with tracheostomy patients, and each patient is different the way we deal with them. But we try our best job to achieve the goal of decannulation with the tracheostomy patients.
Great. Thank you. Dr. Abdulrahman, Dr. Abdullah, is with us? Dr. Abdullah.
نعم السلام عليكم. نعم I can hear you.
السلام عليكم دكتور، كيف الحال؟ طيب.
الحمد لله، شكرا جزيلا.
تكلمت أعتقد عن سكيل عشان evaluation. Sorry, I speak in Arabic a little bit. Scale of evaluation for tele-rehabilitation that you mentioned. Could you elaborate a little bit on this, because I think we missed it while you were talking about that issue.
Yes, the idea started years ago when I was reviewing the literature and trying to do studies on tele-rehabilitation. But I mean, the recommendation was why not to start from step one to measure acceptance of tele-rehabilitation before we go and waste resources, and we don't know at that time whether people will like it or not. So reviewing the literature, we did not find any specific scale to measure acceptance of tele-rehabilitation. Acceptance, what do we mean by acceptance? Part of it is the intention, whether they are willing to use tele-rehabilitation in the future or not, and with list of barriers, expected barriers, and demographics. And based on I designed the scale myself during my study in USA, and using the scale now after validated and did some tests for reliability. Using the scale now will help us to identify those patients or potential users who will accept tele-rehabilitation more and have the demographics that they are willing to use tele-rehabilitation more. I mean, in terms of age, distance from the center, duration of the disease itself, all these factors could be calculated within that scale to give you a score that will give you an idea whether this patient or this population is accepting telehealth or not. And fortunately, the scale has two versions, one for healthcare practitioners and one for patients, and are ready to use, and they are free.
Thank you. Thank you, Dr. Abdullah.
You are welcome. Thank you so much.
Hamad, is Hamad there?
I believe we reached to the end of this event. On behalf of the organizing committee, I would like again to thank all of you for attending our event. Hope you have learned a lot and update your knowledge and experience eventually, and apply this in your day-to-day practice. And I believe the change is the end result of all true learning. Again, very big thanks to all of our international and national guests speakers for sharing with their experience and knowledge during our event. Wish to see them in future events. Thank you again, and have a nice day, remaining day.
Thank you.